بسم الله الرحمن الرحيم. الحمد لله رب العالمين. اللهم صل على سيدنا محمد وعلى آله وصحبه وسلم. إن شاء الله subaxeenii labaad aynu bilaabaynaa. marka qofkii ID cardkiisa waa inuu qof kastaaba soo marka waxa aynu insha Allah diyaar iminka inoo ah insha Allah lecture-kii koobaad. دكتور عبد الرشيد هو resident جامعة la yidhaahdo University of Wexner, wuxuu inagala hadli doonaa insha Allah create guidance and counseling for primary care. cabdirashiid wuxuu ka mid ahaa dhakhaatiirtii ka baxay jaamacadaha dalkeenna oo markii dambena Maraykan waxbarashadiisa ka sii watay. marka dhammaanteen insha Allah waa inuu wada dhegaysano. waxaan doonayaa inaanu buuq iyo qaylada la joojiyo insha Allah si fiican casharadaas aynu uga faa'iidaysano u dhegaysano haddii ay beenmo. جزاكم الله خير. soo dhawow Dr. cabdirashiid.
عليكم سيفي عمر بن المقلة ترى
si fiican baan kuu maqlaynaa.
عليكم ورحمة الله وبركاته aad baan u salaamayaa dhammaan kasoo qaybgalayaasha shirka, sidoo kale qabqaabiyayaasha shirka SAHA 2025 I think it's 5th convention. magacaygu waa Dr. cabdirashiid axmed, waxaan ahaa dhakhaatiirtii ka qalin jebisay jaamacadda Hargeysa 2010 batchkii labaad ee ka baxa jaamacadda Hargeysa. iminkana ka ah resident jaamacadda Ohio State University, sidoo kale ah student Graduate School of Public Health at Ohio State University, oo aan ka dhigto Master of Public Health with a major of Community Health Leadership and Management. aad baan ugu farxsanahay maanta inaan la hadlo dhakhaatiirtii koleyntooda badan way iga dambeeyeen, laakiin dhakhaatiir badan oo is naqaano waxa jira Burco jooga oon soo wada shaqaynay. aad baan idin soo dhaweynaya dhammaantiin. Let me know if you can see my slides. Slidesku ma muuqato.
wuu muuqdaa. haa wuu muuqdaa si fiican.
Okay. waxaan doonayaa inaan saaka ka hadlo my career journey, sidoo kale wadada aad haddii uu hamigaagu yahay inaad takhasus ka raadsato waddanka dibaddiisa, waddooyinka aad mari karto. waddooyin badan baad mari kartaa, meelo badan waxaa jira opportunities badan yaalaan. iminka waddanku sidii hore maaha, jaamacadu sidii hore maaha. informationku meel kasta waa available. Marka optiono badan baa jira. Anigu waxaan xoogaal u ahay ka Maraykanka oo aan waddadiisa maray. Wixii ma garanaysaa aan kala kulmay, caqabadii aan kala kulmay iyo processkii aan maray ayaan si kooban idinla sheergalay doonaa hadduu ilaahay idhaa. Sidaan soo sheegay, waxaan ka baxay jaamacadda Hargeysa 2010. Marka waxyaabihii igu dhaliyey ama igu abuuray inaan raadsado international postgraduate studies xilliga 2010 waxay ahayd very long time ago. Informationku available siduu imika u yahay muu ahayn, opportunitiesku siday available imika u yihiin may ahayn. Marka waxyaabihii igu kalifay in fikirkaasi ugu dhasho waxa ka mid ahaa, may jirin meelo imika Ethiopia oo kale fursado badan baa jira. Dhakhaatiir badan oo waddanka ka baxay Ethiopia tagaan ay residency kusoo sameeyaan. Dhakhaatiir kale waxaa jira meelaha kale Afrikaanka kale, Imaaraadka, UK, meelo badan oo waxaa jira imika furfurmay, laakiin waxaasoo dhan may jirin beriga. Dhakhaatiirta qalin jabisay markaa waxaa raadsanaysay postgraduate-kuna aad bay u yaraayeen. oo
Dr.
sidaa
Abdulrashiid,
sheegay.
slide-ka yar weynee walaal fadlan, slide-ka yar weynee.
Okay, 1 second. Let's see. Is that okay? Gabadhan ma la arkaa talo imika?
waa sax, laakiin waxaad isticmaashaa bahalka yare koobka yar maaragtay si ay uga baxaan slide showga xaggan. Okay.
Good.
Okay,
Okay.
sax wey.
All right. Marka waxyaabihii igu kalifay wax ka mid ahaa opportunity la'aanta. Waxyaabihii kale run ahaantii igu dhiirigeliyey inaan raadsado waxay ahayd saameyn ay igu yeesheen mentorship fiican oon helay early internship year oo ahaa 2010kii, weliba bilihii ugu horreeyey markii aan jaamacadda ka baxay. beriga internshipku structured buu ahaa. waxaa gacanta ku hayay King's College. wuxuu ahaa ma garanaysaa u cusbaa, dardar baa loo hayay, marka uu structured buu ahaa. xilligaa waxaa ka mid ahaa 7 dhakhtar oo loo diray Bournemouth Regional Hospital. halkaas waa kula kulmay unitkii laygu asaangareeyey oo ahaa pediatriga, dhakhtar family physician oo Maraykan oo xilligaa joogay la odhan jiray Dr. David Fox, kaasoo run ahaantii ii bilaabay residencygu wuxuu yahay, American residencygu siduu u shaqeeyo, iyo ma garanaysaa xog badan uu iga siiyey systemkaas oo aanan markii hore niyad ku haynin. formashkii ugu horreeyey martaasaan ka helay. sidoo kale dhakhtarka Bournemouth joogay training stylekiisu ka duwanaa trainingkii aanu ku aragnay isbitaaladeenna iyo magaranaysaa local hospitalskeena. wuxuu ahaa dhakhtar stylekii residencyga Maraykanka trainingkiisii la yimi Bournemouth Regional Hospital, oo trainingkiisu wuxuu ahaa very difficult. taasina waxay keentay in friction badan uu ka dhex yimaado isaga iyo dhakhaatiirtii uu traingarey jiray iyo ardaydii. sababtuna waxay challenge-ka uu ku samayn jiray ardayda iyo magaranaysaa internska. fursaddaasoo run ahaantii aan xilligaa u arkay fursad qaaliya oo imika markaan dib u eego trainingkan xaggan ku qaatay markaan internka xaggan imika ahaa residentka iyo trainingkan berigaa maray, waxyaaba badan oo iskaga mid yihiin ay imika ii muuqatay. xilligaasaan markaa bilaabay inaan ka fikiro sidii aan u heli lahaa training noocaas. laakiin maan arkin markaa waddo cad oo ii muuqatay oo ah in magaranaysa aan ku gaari karo. waxyaabihii aan ku fikiray ugu horreeyey waxaa ka mid ahaa sad fiisa u heshaan maraykanku iskama tegi karo. waynu ognahay waddankeena iyo baasboorka iyo immigration problems oo dhan oo ay jireen. marka wixii ugu horreeyey miyadeeda wuxuu kusoo dhacay wuxuu ahaa inaan apply gareeyo bahalka lotteriga la idhaa oo nasiib ah. oo iska apply gareeyey. kadib trainingkeygii baa iska watay. waxaan kusoo noqday Hargeysa. markuu trainingku ii dhammaaday, qodobkii labaad ee isaguna isii dhiirigeliyey ee igu abuuray inaan hamigeygii ahaa inaan training international helo aanay ka tanaasulin wuxuu ahaa markii aan training ka bilaabay isbitaalka Hargeysa Group Hospital oo aanu ka furnay beriga neonatal intensive care unit aan isbitaalku lahaan jirin, kaasoo ay gacanta ku hayeen Norwegian pediatricians. taasoo iyaduna mar labaad ii noqotay exposure ah inaan helo training ah international standard oo magaranaysaay hamigeygii sii cusboonaysiisay. waxyaabihii kale ee aan ka faa'iiday trainingka waxaa ka mid ahayd in aan helo trainino dheeraada oo ka mid ahaayeen training aan kusoo qaadanay isbitaalka Black Line Hospital ee Addis Ababa, NICU-giisa, sidoo kale isbitaalka ku yaala Kenya oo magaalada Kijabi, kaasoo isaguna aan training noocaas kusoo qaadanay. unitka isbitaalka guud ee Hargeysa ku yaala waxyaabihii kale uu ii sahlay waxaa ka mid ahayd in aan 2013kii aan ku fikiro in aan sameeyo international publications oo aan xilligaa cidiba niyadda ku haynin. waxaana sabab u ahayd inaan tallaabooyinka xilligaa qaado exposurekan international trainers iyo mentorska aan la lahaa. labadaydii international publicationska ee ugu horreeyey waxaan ka sameeyey NICU, kaasoo aan ku daabacnay international journals oo run ahaantii markii aan xaggan imika iga caawisay, waayo requirementka markaad residencyga apply garayso waxa ka mid ah inaad leedahay inaad publication samaysay. marka waxaan uga socdaa waxa weeyaan haddii hamigaagu yahay inaad international training hesho, inaad adiga oo halkaaga jooga aad preparation ka bilowdo. hadday noqoto inaad itixaamada board examska aad u diyaar garowdo, hadday noqoto inaad publication samayso, hadday noqoto inaad connections samayso oo magaranaysa hadhow tole hadii aad reference u baahato kaa caawiyo magaranaysa si aad u hesho. intaa marka laga yimaado muhiimadda ama haddii aan yar dul maro registrationka USA residencyga, ECFMG kule qof kasta u yaqaanaa. ECFMG registrationka u horeeya oo requirementkiisu uu yahay in ay jaamacaddu ka registaraysan tahay WHO. jaamacadda Soomaalida inta badan ka registaraysan yihiin. ECFMG-du markaad registrationkeeda hesho waxa aad geli kartaa USMLE stepska oo step 1 ood ku geli karto wadamadeena jaarka sida Kenya ama Dubai, meelahaad ku geli karto haddii aad diyaar tahay. step 2ga sidoo kale waa lagu geli karaa. step 3ga oo imtixaanka u dambeeya oonad u baahnayn inaad haysato markaad applicationka residencyga samaynayso, ayaa isagu u baahan inaad xaggan timaado. laakiin step 1 iyo step 2 haddaad haysato, sidoo kale ECFMG certificate baa jirta oo marka aad imtixaan yaroo communication skillskaaga iyo clinical reasoningkaaga iyo waxyaabaha lagu tijaabiyo aad baasto, aad helayso dad step 1 step 2 iyo ECFMG certificate aad haysato waad apply garay kartaa USA residenceska. waxba kusii dheeraan maayo. ECFMG-gu waxay leedahay website, websitekaas information dhan ku jira. USMLE-ga sidoo kale itixaamadu meel walba waa lagaga sheekeeyaa, preparation materialkooda. cilmiguna inta badan waxa weeyaan kan aynu halka ku hayno wax kaga duwaya ma jiro run ahaantii. waa intaad adigu isbarto un. itixaamadani way adag yihiin, laakiin hadaan anu ka baxay waad ka bixi kartaa. qof kastaa ka bixi karaa u diyaar garooba run ahaantii. meelaha kale ee iminka dhakhaatiirtii wadanka ka baxay ay tegeen waxaa ka mid ah UK oo isaguna itixaamo gaara leh. sidoo kale waxaa jira dhakhaatiir jaamacadeena ka baxay oo jooga qatar, qaar Australia jooga. adduunka meel walba way joogaan. sababtuna waxa weeyaan jaamacad kasta oo WHO ka rajiskaraysan qofka ka baxa international exam kasta u geli karaa, international residency kastana waa apply garan karaa. waa qof iyo magaranaysaa siduu processka u maro. haddii aan intaa kusoo koobo oo aan soo ururiyo talada aan siin lahaa qofka dhakhtarka ah ee maanta ama dhammaynaya jaamacadda Burco ama jaamacadda Hargeysa ama jaamacadda Boorama ee hamigiisu yahay inuu helo residency ama USA ama UK, inuu preparationka bilaabo maanta. hadday noqoto inuu waxyaabihii basiga ahaa ee magaranaysa itixaamada u diyaar garoobo, hadday noqoto in uu publication sameeyo, uu case studies sameeyo. case studieska ayaa ugu fudud publicationska la aqbalo marka aad apply garaynayso residenceska. dad case interestina hesho oo aad qoraal yar ka diyaariso oo joornaalada adduunka u kala dirto, laga yaabaa inay iska aqbalaan, kadibna aad publicationka tadhitoole ku darsato CV-gaaga. sidoo kale haddii aad hesho magaranaysaa dhakhaatiirta internationalka ee wadanka imanaya ee nala shaqeeya, iyadana inaad advantageka aad ka faa'iidaysataan oo magaranaysaa connection aad la samaysid oo talo weydiisid oo magaranaysaa haddii aad contact kala hadhi kartid aad kala hadhid. ciddii u baahan in informationka wixii faahfaahina magaranaysaa ama su-aalo dheeraada qabta way su-aalahooda waa laga jawaabi doonaa. ciddii kalena contact informationkayga waxgaas ku qoran yahay way la soo xiriiri karaan. ciddii su-aal haysa, hadday noqoto processka, hadday noqoto preparationka, you can ask.
miyay jiraan cid su-aal qabta insha allah oo dhakhtarka weydiinaysa wax su-aala? okay. exactly waa sax weeye. marka haddii in yar bal Dr. Cabdirashiid aad faahfaahin ka bixisid bal requirementka maxay tahay aad noogu yar celisid iyo eligibility criteria haddii way fiican tahay to doctor xuseenna xogaa buu ku dari doonaa isaga laftiisa wuxuu ka mid yahay dhakhaatiirtii dariiqaa martay
And requirementku waxa weeyaan horta marka ugu horeysa in iskuulkaagu aad shahaado ka haysato school ay WHO recognize garaysan tahay oo ku jira waxa la yidhaahdo WHO World Directory website. Marka jaamacadahayna intooda badan way ku jiraan, jaamacadda Hargeysa, Camuud, jaamacadaha koonfurtoodna way ku jiraan. Stepka markaad soo dhaafto waxa aad dabeeto bilaabaysaa inaad ECFMG ama commission u qaabilsan foreign medical graduateska u dhexeeya iyo US systemka aad registration ka samaysato, kuwaasoo samaynaya soo verify garaynaya shahaadooyinkaaga, sidoo kale identitygaaga verify garaynaya, fiyar bay dadka ka qaadaan. Markay intaa kuu sameeyaan, berigii aan bilaabayo kale verificationka waxay ku samayn jireen inaad shahaadooyinkaaga mail ugu dirto oo ayaguna dabeete mail ugu soo jawaabaan. Wax system noocaasaa jiray. Kadib markii aan arkay inaanay suurtagal ahayn, waxaan jaamacadda Hargeysa allah u naxariista doctor Diiriye ayaan la soo xidhiidhay. Kadib ECFMG-dan la hadlay, waxaan ka codsaday inay noo samayn karaan online verification u dhexeeya jaamacadda Hargeysa iyo ECFMG-da. Marka waxay igu yidhahdeen jaamacadda codsiga ka yimaado. Doctor Diiriye allah u naxariistee ayaa u diray codsiga, way soo jawaabeen, sidii baan systemkii ku setup garaynay. Marka imika within 2 weeks bay ku qaateen shahaadooyinkaaga la confirm gareeyay inay yihiin valid jaamacadda Hargeysa ama jaamacadda ay ka yimaadaan. Intaa marka soo dhaafto ee ay registration kuu sameeyaan, waxa la yidhaha ECFMG number bay ku siinayaan. ECFMG numberka haddaad haysato waxaad apply garayn kartaa USMLE step 1 oo ah stepka u horeeya, ama step 2 ka doonto baad ku bilaabi kartaa. Kaa marka baasto ayuubaad step 2gana aad geli kartaa. Stepska marka dhamayso, step 1 iyo step 2 marka dhamayso, ECFMG certificate baad codsanaysaa oo iyadana ay ku xidhan tahay imtixaanka ayana ingiriisiga la yidhaha OET oo online writing iyo speaking oo communicationka inaad magaranaysaa qof dee ingiriis ku hadlaya aad communication aad si fiican loo samayn karto lagu xaqiijinayo. Kaa markaad baasto ee aad shahaadada ay ku siiyaan ECFMG certificate, labada imtixaana aad haysato, then you can apply for residency. Laakiin waxa kuu dheer requirementkii u khaaska ahaa USMLE-ga iyo residencyga iyo programmadu ay eegayeen markay arkaan applicationkaaga, oo ah in aad leedahay referenceskuna inta badan waxay ku xidhaan programmada intooda badan ay ku xidhaan inaad leedahay US clinical experience oo aad inuun exposure ku noqotay US health systemka, oo magaranaysaa aad la qabsan kartid systemkooda. Taana waxaad ku caddaynaysaa dhakhtar Maraykan jooga inaad la shaqaysay ugu yaraan 2 to 3 weeks ama 4 weeks meelaha uu dhakhtarkaas kugu qoro recommendation letter. inta badan waxaa loo baahan yahay ilaa waxay codsadaan 3 recommendation letter oo ka yimi US basic physicians. inta badan waa ta ugu adag ee dadku ku dhibaatoodan inay helaan, sababtuna ay tahay dee way adagtay inay dadku immigration magaranaysaa ay intay halkan yimaadaan oo magaranaysaa ay visa ku yimaadaan kadibna ay clinical experience ka qaataan haddii qof si kale ku yimaado mooyaane. requirementku inta badan waa iska inta haddaad haysto recommendation letterska ECFG certificate-ka iyo itixaamada iyo sameli stepska aad soo baastay. Requirementsku inta badan waa intaa.
waad mahadsantahay jazaaka allah khayr cabdixakiina walaal soo tirin ka yarta kolley xuseen baynu isaguna insha allahu tacaala inoogu dari doono laakiin jaamacaddeenna way ku jirtaa ECFMG iyo maaragtay World Directory of Medical Schools labadaba waxaana jirta in inantaa doctora muuna cabdullaahi maraykan bay joogtaa jaamacaddeenay ka baxday jaamacadda burco waana inantii ugu horreysay ee inoo gelaysa insha allahu tacaala USMLE step 1 marka dhammaan dukumentiyadeedii oo dhan waanu u dhammaystirnay riboodho fara badan baa laga rabaa qofka runtii in ilaa iyo year 1 maalintu galay report aan academic ahayn oo dee kii performance-ka ahaa oo akhlaaqda iyo maaragtay dadnimada iyo waxaasoo dhan marka ardayda laftooda inay maaragtay laanno annagu wax alla wixii dhacay sideedaanu u qoraynaa marka inuu arday kastaaba uu maaragtay hadhowto annagu waxaan jirin ku qori mayno iminka reportka muno oo kale haddaan idin tuso bahalka ah wordka ilaa iyo maalintii ay soo gashay foundationka ilaa iyo maalintii ay qalin jabinaysay reportkeedii waanu qornay waanay naga codsadeen qoladaasi ECFMG-ga marka innaga ECFMG-ga numberkeennana waad aragtaan oo ka halkaa ku qoran marka ardaydeena way geli karaan way apply garayn karaan waxyaalaha doctor cabdirashiid sheegay runtii waxaa ka mid ahaa in caqabadaha maarata qofka marka uu haddii abayd maayo haddii iminka aanu isnidhaahno masalan ardayga horaha u yar socdo waxa weeye يعني runtii caqabad baa kaaga imanaysa ardayda leeno ardaydu ma rabaan in magaranaysaa ay la challenge gareeyo oo ay shaqo dheeraada qabtaan intoodii yaraydee ay maaragtay samayn jireen wax ka badan marka in ay ogaadaan iminka cabdirashiid markii uu la kulmay uu dabadda tegey ayuu arkay runtii faa'iidada ay lahayd ninkii dhakhtarka ay maraykanka caqabadda ay ka qabsatay isbitaalka boorame marka ardaydeenu waa inay diyaar u noqdaan insha allahu inay waqti dheeraada ay bixiyaan inay ay maaragtay ay levelka challenge-ka ay sare ugu soo kacaan leannahu inaad hore u martid ood hore u socotid oo aad ma garanaysaa runtii waxay u baahan tahay dadaal dheeraada marka iminka waxaan isagana insha allahu kelmad siin doonaa xuseen oo inala jooga xuseen hanfi oo isaguna ka mid ahaa dadkii yani jaamacadda soomaaliya ka baxay xamar waqtigii dambe talyaaniga waqtigii dambena maraykan qabtay bal marka isaguna wixii uu inoogu darayo experience-ka aan kusoo dhaweeyo doctor xuseen
السلام عليكم ورحمة الله وبركاته ملايين قليها اوكي marka horta warka waxa inoo dhameeyay oo aad u mahadsan Dr. Cabdirashiid oo idin ka mid oo dhawaan jaamacadda Hargeysa ka baxay wixii information ee aad u baahnaydeen badankeeda uu idin siiyay marka aanu waxaan ku dari lahaa oo kaliya aniguna waxaan ka mid ahay si dariiqa uu Cabdirashiid maray dadkii maray waqti imika laga joogo 20 sano ka hor marka anaka mushkiladaha ugu badnaa waxay ahayd markii aanu jaamacadda ka qalin jabinay talyaanigan waxbarasho u tegay talyaanigan joogay marka qorshe wuxuu ahaa inaan ku soo noqdo wadankii oo markaan soo dhamaystay waxbarasho inaan ku soo noqdo laakiin taasi way suurtoobi weyday oo wadankii waatii dagaaladii waxaasi ka bilowdeen marka waxaanu isnidhi halkee idiin furan marka eed mari kartaa marka informationkuna berigaas sidan ma ahayn oo internetka iyo howlahan fara badan ma jirin. waxay ahayd inaad library-ga tagto aad wax raadsato adigu daba gasho. marka sidaydaba anigu markii aan jaamacadda ku jiray medicineka xamar ayaan waxaan la xiriiray maraykanka warqad u qoray marka internetkuna iyo waxaasina ma jirin. marka way ii soo jawaabeen waxay yidhaheen haddaad maraykanka rabto inaad timaado waa inaad imtixaanka USMLE lama odhan jiray berigaa magac kaluu lahaa MBMA buu ahaa inaad imtixaankaa geshid. meesha keliya inoogu dhaweyday markaa lagu geli jirayna Nairobi bay ahayd. marka waad garanaysaa arday jaamacad ku jira inaanu awoodi karin inuu intuu iskii diyaarad u raaco uu Nairobi tago imtixaanka ka galo. marka waxaan is idhi ta kugu dhawee keliyaad ku samayn karta waxa weeye mar aad opportunity heshood bannaanka tagto inaad imtixaanka geli karto. nasiib wanaag waxay ii suurta gashay markii aan Talyaaniga tegey inaan imtixaankii step 1 iyo step 2 halkaa ku galo. berigaa computer laguma geli jirin written buu ahaa oo hotel intay kiraystaan dadku ilaalina keenaan buuggaasaa lagu qaybin jiray saasaad ku geli jirtay. caqabada kale anaka markaan na hortaagnayd markii aan Maraykanka tagay si aan fiisaan helay VC baan ku tegay. waxay noqotay markaad residentka dalbaysid waxay kaa rabaan ECFG office-ku wuxuu kaa rabaa inay jaamacaddaadii la soo xidhiidhaan. marka jaamacaddeediina markaa way burburtay waa la xiray. marka waxaanu ku nidhi waraaqa kama keeni karno. marka waxay nagu xidheen in saddex dhakhtar oo Maraykanka ka shaqeeya oo ku yaqaana inaad jaamacadda ka soo baxday inay ku markhaati furaan. tiina way nagu adkaatay. marka cid jaamacaddayda ka soo baxday oo Maraykanka ka shaqeysa may jirin. nasiib wanaag laakiin waxaa jiray dhakhtar Soomaaliyeed oo New York State ka shaqeeya. dhakhtarkaasaa markaa dhakhaatiirteydii u horreysay dhakhtar Abiib nin la yidhahdo oo markaa noogu horreeya meesha tegey isagaa warqad u qoray. dabeetana laba dhakhtar oo la shaqaynayay ayuu beriyo yidhi waa in adeer please caawiyo laba warqadood oo kale laba recommendation kale dhakhtarkan igu qora. nasiib wanaag way ka aqbaleen. waxay yidhahan adigaanu ku tarasgaraynaynaa inaad ninkan garanayso inuu jaamacadda ka soo baxay marka waanu kuu qoraynaa. sidii bay ugu qoreen. sidii buu ku bilaabay markaa residenskii. markii aniga iyo ninaanu saaxiibnahay aanu Talyaaniga ka tagnay oonu dhakhtarkaa kale ku xignay marka dhakhtarkii hore Soomaaliga iyo dhakhtarkan kaloo markaa residentkii ku jira iyo qof kaloo ay meel kale ka heleen saddexdaasaa noo qoray. ani iyo Dr. Cabdilaahi markaanu residenskii gallayna markaa dadkii kale naga dabeymanayay way u sahlanaatay oo saddex baanu ku joognay markaa residenska ku sameynaynay. marka annaga u qori jirnay 3 letter oo recommendation ah. marka saasay iskaga hawl badan tahay. laakiin haddaad qofkii adkaysta waa meel laga soo bixi karo wax si fiican aad wax uga baran karto. marka qofkii opportunity ka hela waa wax fiican weeye. ta kale waxay ku hawl badan tahay marka aad meeshaa tagto inaad adigu noloshaadii dabartid. adigoo waxaa laga yaabaa noloshaadii dabaraya imtixaanadiina aad diyaarinaysid. marka waqti badan bay kaaga baahan tahay inaad library-ga joogtid. waxaa jira kambaniyo waxoogaa lacag laga bixiyo oo dabeetana kaa caawinaya sidii aad imtixaanada u diyaarin lahayd. marka waxaan idinku boorinayaa inaad samayn kartaan oo aad adduunyada dhan la tartami kartaan. hayse odhanina jaamacadda burcaad ka baxdeen ama Hargeysaad ka baxdeen oo dadka ama gaari kartaan. waxaas waa been wey. inta aad taqaanaan unbay yaqaanaan. idinkaa weliba haddaad doontaan ka badin kara. iminka dhakhaatiir badan oo waxaanu nahay Maraykanka joogta caadi baanu la tartanaa. iminka 20 sanaan ka shaqaynayay. marka ha ka werwerinaysaa inta aad taqaano un haddaad si fiican u baratood adigu dadaasho waad gaari kartaa. marka raallihaada hadalka yaanan isku sii badinayn laakiin haddaad wax su'aaloo dheeraada qabtaan waad i weydiin kartaan. maasha
waad mahadsantihiin dhammaantiin doctor cabdirashiid iyo doctor xuseen aad iyo aad baa u mahadsantihiin haddii aanay wax su'aali jirin waxaynu u gudbi doonaa casharkii labaad insha allah
Thank you.
Waay mahadsanid adeero halkan zoomka eeg tiimka inay ku jiraan inuu doctor ibrahim inuu ku jiro computerka ama ii soo dhow doctor ibrahim Abdullah Hussein ma ka horeeya okay doctor Abdullah Hussein diyaar miyuu yahay minu maqlayaa
السلام عليكم.
عليكم السلام ورحمة الله وبركاته.
All right. Let me see if you can see my screen. First of all, I want to say, meanwhile, as I'm sharing my screen, I want to thank everybody who organized these, and like some of my colleagues who said before me, this pathway is manageable for anybody. All you just need is mentorship. So make sure you have a mentorship, you have people ahead of you, ask them questions. As a matter of fact, I did train here in Kenya and then moved to the States 7 years ago, and with the similar pathway like some of my colleagues. So with that in mind, I'll go ahead and let me know if you can see my screen.
waan arki doonaa insha allah doctorku wuxuu inoo siin doonaa cashar ku saabsan secondary stroke prevention
It was not stroke. The topic for today is pulmonary embolism. That was for last year. The stroke was for last year. So let me know if you can see my screen.
yes
Yeah. So the topic for today is pulmonary embolism, how to diagnose and how to manage in resource-limited settings. So as we know, pulmonary let me know if there's any interruption of the internet or anything. So the incidence, as you can see, it's quite high. It's almost 100 cases in 100,000 people per year. And it's the third most common cause of cardiovascular death in the state after cardiovascular, coronary artery disease and stroke. I wasn't able to find a lot of data for Africa or for resource-limited settings. But as you can see, it's quite common. And when it happens, especially in critical care settings, you have to pick it early. Otherwise, it has a high mortality. So the etiology and the risk factors, any of the three can happen because of the virtuous triad. The blood becoming thicker, blood staying in one place. For example, in AFib, AF flutter, just it fibrillating, you have stasis of blood or either endothelial injury. There's some genetic factors. The most common is the protein C and S. There's also factor 5 related. But in my opinion, the most common etiology and risk factors is the acquired one. A patient comes to your hospital, recently had a surgery or malignancy, or even pregnancy itself. Or a patient comes in, they had a travel through a flight, and they had maybe 7 or 15-hour flight. Oral contraceptive pills as well, and smoking. So the pathophysiology, you have the clot obstructing the flow at the pulmonary artery. And once that happens, you have, because now there's a backflow and there's a lot of pressure, you have the RV, right ventricle, straining and dilation. And as a result of that, because always the LV is kind of muscular, is bigger than the RV. So once you have a lot of back pressure and dilation and straining of the right ventricle, you have the left ventricle, decreasing in filling, and as a result, because it's being pushed away, you have decreased cardiac output. And that's how most of these patients end up in shock. For the hypoxia, it's just because that you now have oxygenation, oxygen coming to your lungs, but there is no blood flow going to the lungs to have that exchange. So the presentation, this patient comes in, they're short of breath, they have this chest pain, sometimes, cough, their heart rate is high, their respiratory rate is high, their neck vessels is engorged. So you can see that, and they're very cyanotic. So because of that, we're going to do a case. This was a case report that was, I think, done like 10 years ago. But at the same time, these are very common cases which come into your hospital. So these are 26-year-old female, 24 weeks gestation. She comes into the ED, to the emergency department, with 4 hours of shortness of breath and chest pain. There are no risk factors or drug consumption that was reported. At the ED, the patient was to be she was short of breath, she was cyanotic, and she was hypotensive. As you can see, the blood pressure, is low. The heart rate is high, very hypoxic, right? Saturating 80% on 6 liters nasal cannula, and very tachypnic, respiratory rate 28 to 30. They did an EKG at that particular hospital, and this patient had sinus tachycardia. So I guess the question is, this patient comes into your hospital, they're unstable, they are at your emergency department. What should you do next? And to be honest, just because now we all know it's PE, but in reality, the way you will approach this case is your ABC. So don't forget your ABC. Make sure the airway is protected. For breathing, if they're now 80% on 600 nasal cannula, maybe you can bump it up, right, with a high flow. And you should have the equipment to intubate if needed at the bedside. You have to be ready. But the most important thing is your circulation, right? You want to have 2 wide IV bore on your peripheral sides. And this is because even if you decide to intubate, you need that access, right? So you need to have those 2 IVs. You need to start fluids, because at this time you don't know if it's PE or not. It's undifferentiated shock. So start your fluids. If they're very hypotensive, this is the time you also have to start your vasopressors. And in addition to that, you have to do a cardiac monitor, to do the EKG, to make sure. So those are the ABC you have to do first, before even doing anything, before even sending a patient to imaging, because they'll probably crash before going to the imaging. So for this case, they did exactly that. They bumped up the oxygen to a higher level of oxygen. They made sure they had 2 wide IV on peripheral side. Remember, even in terms of fluid going faster into your body, gauge 14 or 16 peripheral IVs goes much faster than even a central line, and it's much quicker even to put. So they did the IVs, they did the cardiac monitor, they did the EKG. As you can see, this patient required some levo-fed, norepinephrine. And at that time, because the patient was too unstable, they couldn't take the patient to a CAT scan. because it's most common the way we can figure out if it's PE or not is through a CAT scan. So this patient was too unstable to go for a CT. But what they did was what you guys have been doing for the last 1 or 2 weeks. They did a POCUS, point of care ultrasound. And with a POCUS, it's a quick and dirty way of knowing what type of shock you have. If a patient comes in, they're shocky, you have no idea what's going on, or maybe peri-arrest, and you don't know what's going on. If you put that probe in that person's chest to see just how the heart is doing, to see how the RV, the left ventricle is doing, it will help you. And I'm sure you might have another training for the ACLS and BLS to find your H&Ts. So the 3 T's, the tamponade, the tension pneumo, the thrombus, the PE and the MI, those ones can be figured out with your POCUS, your point of care ultrasound. And those are one of the main reasons why patient will be hypotensive, and that you can easily pick up with a probe. So when they did a POCUS for this patient, as you can see, there was distended right ventricle with free wall hypokinesia, which means that it was just barely moving. And the intravesicular septum, which divides the right ventricle from the left ventricle, normally the LV is more masculine and has more pressure, and the RV is a little bit weaker. So once you see the intraventricular septum going towards the LV, it tells you there is so much pressure which is building up at the right ventricle. So that's what they saw. And also they saw the IVC, inferior vena cava, being dilated. So these are very, it points towards PE picture. All right. So that's what they saw. And although this patient is pregnant, there's a relative contraindication to thrombolysis, and we'll talk about that. They saw it's a life-threatening situation for the mother and the fetus. And after informing the family and obtaining the written consent, they were able to give the thrombolytic, which also sometimes is known as clot busters. And then we'll talk about that after this. And then after that, they gave the patient, of course, heparin, anticoagulation. And 2 hours later, you can see the blood pressure started becoming better, normal hypotensive, normal, tachycardia much more improving, normal hypoxic. And of course, they had to make sure they monitor advance that, what can happen with these clot busters. Pelvic exam, ultrasound, which showed, regular fetal heart rate. There was no abnormal bleeding. And 24 hours later, with their complete echo, there was improved hemodynamics, and there was no RV dilation. And the IVC was much better, it was less than 2.1. And this particular patient was able to be transferred out of the ICU in 5 days and was discharged in 8 days. So with that in mind, there's a lot to unpack. As you can see, there are clinical classification of PE. Most of the time, we're lucky we see very stable PE patient. But a lot of times, as you can see on the extreme right, I don't know if you can see my cursor. Can you guys see me? No? Can you guys hear me? Can you guys hear me? Question mark.
Continue, doctor. Continue. Thank you so much.
Yeah. So as you can see on the extreme right, hopefully you can see my cursor. There's a high risk PE, which means, and the way I try to think about it is, they have different names. They have some people, they name it as massive PE, others are high risk. But the main defining one is defining factor in the PE is hypotension. If a patient has hypotension, automatically they're in the high-risk PE group. Some patients even come in, or maybe they're much worse than that, they go into cardiac arrest, PA cardiac arrest, and clot in transit. Those are high-risk PE. For a patient who has PE, but their blood pressure is normal, so that's more of, can either be intermediate or low risk. And at the intermediate risk PE, what makes it intermediate basically is the RV. We talked about the right ventricle, the RV dysfunction and injury. And the way I think about the RV dysfunction is if the RV is dilated. Normally the RV should be less than the LV. Once the RV is by size is bigger than the LV, that's a dysfunction. And injury is that, leaking of the enzymes, of the troponins, of the proBNP. The way you can pick up if the RV is dilated or not, you pick it up either by an echo or point of care ultrasound and CT scan. The reason why, especially in critical care medicine, we try to teach ourselves how to do point of care ultrasound is because sometimes with echo, even in the States, it takes a while for them to come and do the echo. You don't do an echo on an unstable patient. Sometimes they take even 4 or 5 hours, sometimes even 24 hours. But with the point of care ultrasound now, what now you have been taught for the last continue is you are the first point of contact with the patient. When you're going to see the patient, you're carrying along with you, the probe, right? So that's the intermediate risk. That's how the patient is more intensive, but they have either RV dilating or strain, or they have leaking of the enzyme, which mostly is troponin and proBNP. The other things like the PESI score and stuff, and we can talk about that. That's for the intermediate risk. For the low risk PE, you have this patient is normotensive, and they don't have any injury to their RVs, and they don't have any dilation to the RVs. So when with the echo or focus or the CAT scan, there is no dysfunction, there is no leaking troponin or proBNP, and normal blood pressure. Those are low risk PE patients. So as you can see here, the massive PE, it has a high risk mortality up to 30%. And this patient, honestly, if there's no contraindication, we'll talk about that. This is a patient who will benefit from systemic thrombolytics. For the submassive or the intermediate risk PE, we'll talk about it. Sometimes it's questionable to give thrombolytics unless there's a lot of shared decision making and the patient is decompensating. And for the low or for the minor or for the low risk PE, you just give anticoagulation. But don't forget, even the others, even after giving the clot busters, you have to give them anticoagulation, and you have to continue anticoagulation, and we'll talk about that. So as you can see, this is the European classification. It's very close to the American Heart Association. Both of the groups agree on the high risk patient. Once it involves hemodynamic instability, that's a high risk, For the intermediate, with the European and American Heart, there's slight difference, but it's almost the same in my opinion. For the European, they also involve the PESI score, and the PESI score, and you can use. There's an app, MD Calc. I use it all the time. People use it all the time. It's an app that helps you figure out any formulas that you can't remember. For the PESI score, this is just a score that if you look at it, it's very easy for you to score one, because if a patient is aged more than 80 or has a cancer or chronic COPD or blood pressure is slightly less than, slightly low, like systolic less than 100 or saturation less than 90, automatically even one of it, you qualify for PESI score. So for the European Cardiology Society, they need the PESI score, that's one, but also in addition to that, they subdivide in intermediate high and intermediate low. And the way they do that, as you can see on the extreme right, they use the RV dysfunction, which means either dilation or straining, and that can be appreciated with imaging. And also there is elevated cardiac troponin levels. So if you have both of them, if you're leaking the enzymes, and which shows the injury, RV injury, and if there is an RV dilation or strain, those are two things. Once you have those two things, you're intermediate high. Once you have only one of those, either just the imaging aspect or just the troponin aspect, that's intermediate low. But otherwise, as you can see, intermediate is a different group, and it's almost similar to the American heart. And yeah, so the question is, for the high risk PE, we've talked about it. So what do you do? Do you do just thrombolytics? What's the role of surgery, thrombectomy? What's the role of catheter-directed thrombolysis? You know, and why did they come up with that? And sometimes they're more advanced. That it's challenging for resource-limited centers, like mechanical support, you know, like ECMO and stuff. So for the high-risk PE, for them to receive thrombolysis, so I guess the question is, I mean, when did we adopt that, and what studies helped us to go towards that direction? As you can see, in 1995, there was a paper which was published. It was a small number of patients, it was 8 patients, and they were comparing patients who've received streptokinase plus heparin versus just heparin alone. Streptokinase is the clot buster, is the thrombolytic. Heparin is an anticoagulant versus just heparin alone. And as you can see, out of the 4 patients received it, the other 4 patients just received heparin. And the 4 patients who received the clot busters survived up to 2 years, compared to the other 4 patients who died within 1 hour, 1 to 3 hours at the emergency department. And even the autopsy had proved PE. So I think since then, there was not much studies which was done for high-risk PE, because I guess they thought it's unethical to do that. Other studies that have been done after that, it was just for intermediate PEs, intermediate high, you know. But ever since, this was a study which supporting to date why we use thrombolytics for high-risk PE. So what is a thrombolytic? What is clot busters? So as you can see, the examples are this: the alteplase, the streptokinase. So what it does is it activates the plasminogen to plasmin, and the plasmin by itself is an enzyme which breaks down fibrin. Fibrin is the structural frame of a clot. This is a diagram presentation to show that, as you can see, where the plasminogen activators, the clot busters, come into play, from the plasminogen to plasmin, and which helps, you know, degrade the fibrin into smaller products, right? So the FDA approved clot busters that we commonly use, the TPA, the alteplase, and the streptokinase. That was the ones which a lot of studies which started with, as you can see. And I'm not sure if it's available at the public hospitals in Somaliland, but I'm sure probably might be in the private hospitals, and with a lot of now education, it should be available. So the absolute contraindication. So of course, this medication, they are clot busters. They come with a lot of risk. So if a patient had prior brain bleed, they don't qualify for that. You know, if they have any structural cerebrovascular lesion, if they had a stroke, ischemic stroke in the last 3 months, if they have a malignancy that has spread to the brain. But if they just have a malignancy, I have a family friend who had ovarian cancer, had not spread to the brain, and presented to the emergency department, actually in Nairobi, and was hypoxic, was found to have PE. It was intermediate high, and from, you know, shared decision making, they gave the clot busters and she became much better, alhamdulillah. So I guess so these are for the absolute contraindication you don't give it, like active bleeding, but for the relative contraindication, these are discussions you have with the family, and you try to see, are they decompensating, are they crashing? Because if a patient is peri-arrest, or maybe they're heading towards that, I think they can benefit from it. So the intermediate risk pulmonary. So we talked about now the intermediate high. I mean the high risk, now the intermediate risk PE. There are a lot of studies now after the initial study of the high risk PEs, which was trying to see the benefit of using these clot busters. And the first study, as you can see, is the pulmonary embolism thrombolysis study of the 2014. And they were trying to compare out of the 1,000 patients, ones who've received tenecteplase and heparin, this is just heparin alone. And what they found was it reduced hemodynamic decompensation, no question about it, but it had increased major bleeding and stroke. And because of that, the use of that in PE, intermediate PE, was not justified. There were other studies which came after that, or maybe around that time, the MOPED trial. And the main, I think, objective of the MOPED trial was to see now, instead of giving us the full dose of TPA of 100, let's see if we can give a low dose TPA plus heparin, and just compare with heparin alone, and see. And they saw, there was reduced pulmonary hypertension and hospital stay, and there was no major bleeding in the group that was given the low dose TPA. This was it was a good study, but there was some criticism of being because it had a small size. But of course, I think this was one of the studies which sparked a lot of interest to a lot of research after that to see if people can use low dose thrombolysis. Then there was, of course, the Ultima trial. This one focused on, now they were saying, instead of us just pushing, even if it's a low dose TPA through, your vein, let's look for something like a device, like a catheter, like the way people go to do, they go through, the vessels go the way near the heart, catheter-directed thrombolysis. So they try to go as much as closer to where the clot is with the clot busters and try to bust the clot there. And with this study, it showed improved RV's function in intermediate risk PE without a lot of bleeding. There's also the Seattle study, and I think with this one, it was similar to the other one. This one, they use the ultrasound, the ECOS. They use the ultrasound-assisted TPA. They go all the way close to the clot, and they deliver the clot buster over there. And with this one, it showed improved RV-LV ratio, and there was a low rate of major bleeding. There's also a study after that, now to compare. Is there a specific dose, for the low dose TPA? Is it 24? Is it 8? And with this, the Optalis PE trial, trying to give these clot buster via a catheter-directed method, they saw there was no difference. They had similar improvement in the dosages. They couldn't figure out what was the best dose, but they saw it was effective, whether it was 8, whether it's 24. So what's the recommendation? What's the recommendation? So for the high-risk PE, if a patient comes in, they have a PE, they're in shock, it's okay for you to give thrombolysis, the clot busters. For the intermediate, no routine thrombolysis, and this is now where you have to employ other things, to see if your hospital has capability of doing catheter-directed thrombolysis or suction thrombectomy, or at the same time, if you see this patient, you don't have that, but the patient is decompensating, if it's okay to give those thrombolytic, even systemically, if the patient doesn't have those strong contraindication to that. So only consider in clinical deterioration or worsening of the RV function for the intermediate risk PE. So I'm sure you've had a week or 2 weeks of vigorous training of your point of care ultrasound. So I'll just brush over this. As you can see, so the most important, as you can see, when you have a patient with undifferentiated shock, and you're thinking of PE or other cause. So the most important thing is you go to the apical 4 chamber. As you can see, your apical 4 is the third picture. I don't know if you can see my cursor. The third picture, it's well labeled. As you can see, the RV and the LV, the tricuspid valve, the right atrium and the left atrium. As you can see, your RV is smaller than your LV, right? It's 2/3. The LV is bigger. So once you see the RV is bigger than the LV, and once you see the intravesicular septum going to the LV, it tells you, there's a high pressure in the RV. So those are one of the, just, your eyeball, and that's one of the way you can know. But the other way you can measure, and see how the RV is doing, and one of the ways that if you look at the tricuspid valve, if you go, there is at the edge, you can measure how fast, because the RV, the way it moves, it contracts. Most of its contraction is up and down. So you can actually you can place, you can measure how fast, the tricuspid valve, the annulus, what anchors the tricuspid, how fast it goes up and down, up and down. They call the M mode. You can measure and see, and that taps it, and if it's going, if it's not going vigorously up and down, the RV is weaker, less than 17 millimeters. It's going up, that's good. If you look at the other slide, the second picture, the parasternal shock axis, as you can see, the LV is very muscular, it's cylindrical, it's circular, and the RV is not. So once you see, and you can see, because it's cylindrical, it's muscular, in the center, you see the RV and the LV, that's the intravesicular septum. As you can see, it's bulging more towards the RV. Once it bulges into the LV,
Victor, codkaaga wuu yar yahay.
Can you hear me now?
Yes, now.
Yeah. So as you can see, the second picture, the parasternal short axis, you have the you see the left ventricle is very muscular, correct?
Intii yarada u dambeysay ku soo celi hadda, intii u dambeysay.
Oh, okay. Sorry about that. So from here, maybe from here.
Yes.
Yeah. So as I was saying, I'm sure some of you did have training in point of care ultrasound for a week now, and as you can see, we'll just brush over and see the third picture. The third picture, I don't know if you can see my cursor. The third picture is the apical flow chamber. The apical flow chamber is a quick and dirty way for you to visualize the heart and to see. As you can see, it's labeled here, the RV, the LV, the right ventricle, the left ventricle, the right atrium and the left atrium, and then you have the valves. And the RV is smaller than the LV. And the intravesicular septum, if anything, it's bowing towards the RV, because LV is a high pressure, it's very muscular. And the right ventricle is not as that. And one of the quick and dirty way you can check, if you see your RV is bigger than your LV, because RV is normally is weaker than the LV. If you see the right ventricle is now more bigger, and the intravesicular septum now it's bowing more towards the left ventricle, it tells you there's a pressure building up at the RV. And if it's a crashing patient or is a hypotensive patient, it tells you there is an obstruction that's impeding blood flow from the RV. And one of the most common causes is a clot at the pulmonary artery, as a PE. So that's one of the ways. You look at the RV. The RV is bigger than the LV. That's one of the things. The other thing is that also there's other ways to measure, right? There's other way to measure the LV normally, the way it contracts, almost symmetrical, like in, out, in, out. But the RV mostly it contracts up and down, up and down. And because of that, we take advantage of that and we try to measure. We go to the tricuspid valve, we go slightly lateral, where the annulus, where the tricuspid valve anchors to the wall. And then we try to measure how high that annula, the tricuspid valve, how high it's going up and down, up and down. If it's going up and down, more than 17 millimeters, we measure with an M mode. And I'm sure probably you know about that. If it's going more than, it's a competent RV. It's really contracting. But if it's less than that, it tells you, what, the RV is not contracting as much. The TAPSE. It's called the TAPSE. The other one is if you can look at the second picture, the second image, the parasternal short axis. That's also another way you can easily. It's a very useful window for us. As you can see, the left ventricle, it's very, it's muscular, it's very circular, correct? And the intraventricular septum that you are seeing on the other one, if anything, it's bowing more towards the right ventricle. And the reason is because LV is it's a high pressure. It's more high pressure, it's more muscular than the RV. But once you start seeing that intraventricular, now bowing towards the left ventricle, and then tells you there's a problem, right? It tells you there's a lot of pressure building up in the RV. And they have a name for that. They call it the D sign, it's more of a D and not more of an O or a circle. But that's one of the way you can pick it up. And we will see more images to show us. The top picture, parasternal long axis. To be honest, you can use that to check, but mostly we do that to see, how the LV is contracting, but I would say for the PE, if you want to pick it up, if there's any RV dilation, if there's any intraventricular septum bowing, parasternal short and apical 4 will help you. So as you can see, I don't know if you can see this one. If you look at the second picture, the image, we talked about the D sign, right? Compare now this one and this one. You see how the LV was very circular, was very muscular, and the intraventricular septum was bowing towards the RV. But here you can see it's actually the D sign we talked about, right? The intraventricular septum now is now pushed more towards the LV, and the LV is becoming smaller and smaller. And once the LV becomes smaller and smaller, and LV is the one which sends the blood to the rest of the body, right? Once the LV becomes smaller and smaller, you have less cardiac output, and that's why this patient go into shock, and they go into cardiac arrest. If you look at the third picture, you will see now clearly how the RV is dilated, right? The RV is dilated, and sometimes the McConnell sign, it's not common to see. If you don't see, it doesn't mean it's not PE, but if you see, definitely, it's one of the causes. So what it means is that, so once we talked about RV being weak, the wall is very thin, and when the pressure builds up into the RV, you have the wall of the RV, barely moving, hypokinesia. That's what they call it. It barely moves. But at the same time, once you come to the apex means towards the pointed side, the RV and the LV, sometimes they're tethered together, they're anchored together. So you find the basal aspect of the RV is not moving or barely moving, but the apex is moving faster, and it's moving at the pace of the LV. And that is because it's tethered to the LV and it's moving, with the speed of the LV. So you look at the RV, it doesn't make sense. It looks like the body of the RV is not moving, but the tip or the apex of the RV is moving fast. So that's what they call McConnell sign. Also, the other thing is the tricuspid regurg. So one of the way we also check is that, so once you have too much pressure building in the RV, dilating the RV, automatically the tricuspid valves, they're going to come out. You know, initially they were in touch, but now they're going to be a little bit far away from each other. And because of that, you have functional regurg, you know. And of course, once you continue more, they'll teach you more how to measure that. And but I think when the patient is crashing, unless you do that every day, it's just okay to use these other ones to pick it up. So as you can see, this is our apical flow again, how the normal RV looks. It's less than 2000 LV, right? You can see on the left. So this is the RV, and this is the LV. But once there's more severe dilation, you have the RV much bigger than the LV. That's not a good sign at all. So why are we obsessed about this RV dysfunction? It's because, there's this registry group, the ICOOPA, and they were comparing. And as you can see, in just 3 months, for patients with right ventricular hypokinesia, or compared to a patient without any RV dysfunction, the mortality is almost doubles in 3 months. So that's why if you see a patient, you do your POCUS and you see such a thing, the patient who you want to have a close eye, close monitoring, and you start thinking about management immediately. So this is a CAT scan, but don't forget, if a patient is crashing, if they're hypertensive, there is no role for a CT scan, right? Because they're going to crash in the CAT scan. That's why you have, you can do POCUS. But for the intermediate patients who you have stabilized, they can go for a CAT scan, and as you can see, that's a clot right there, right? And even sometimes I know in resource limited settings, maybe the CAT scan can be down, right? Another reason for you to be very, very good at your POCUS training. So as we said, RV dysfunction can be picked by either an echo or a POCUS or a CAT scan. As you can see, that's a very big RV compared to LV. All right, and once you start seeing that, chances of mortality going up, mortality goes up. So for these patients who they have come to your hospital, right, and of course we all agree, patients with high risk PE, all of them should go to the ICU, you know, as soon as possible. For the intermediate, to be honest, I would say I would prefer an ICU for these patients. Unless you've stabilized them, you've ruled out everything, because this is a time bomb. You don't know when. And for the low risk, as now you decide, do you need to observe them on the medical floor for a day, or you can send them outpatient. But don't forget, once you see this patient, start anticoagulation immediately, because if you don't, it will only get worse and worse. So we've talked about, we say massive PE, rescue, IV, clot busters, right? And of course, if they are contraindication, maybe they have a brain bleed recently or something, even with them, maybe they can benefit from catheter-directed therapies. Some of these patients, they're very sick, they're peri-arrest. Some of them, they require to have, ECMO, which basically is you are trying to buy time, because that, now you're in cardiogenic shock. Your heart is no longer putting out anything. So what you do is you try to buy time. You bypass it to a machine which will help you with lungs and heart functions as you try to stabilize this patient, as you try to, either dissolve this clot, or let the body take care of itself. Then so that's basically the thought process behind the ECMO. For the submassive PE or the intermediate, I think the main thing is just to try to prevent mortality and hemodynamic decompensation. So management of the PE, American cardiologist, College of Cardiologists. So for the normotensive patients, that's the intermediate patient. So the first thing is try to risk stratify them, right? These are the time now you have to do the biomarkers, check the troponins, the pro-BNP, check the imaging. If they're stable enough to go to the CAT scan, that's good. And so that you can see if there is RV strain and RV injury. But by the management, systemic thrombolytic therapy comes along also with significant bleeding. So because of that, you know, if your hospital has options for catheter-directed therapy, that's good. Or some of the hospitals, they do have also suction thrombectomy. So once this patient, as I said, don't forget about anticoagulation, right? All of these patients, whether you have access to a clot busters or not, you have to start anticoagulation. And anticoagulation at least minimum for 3 months if they're provoked. If it's unprovoked, like patients you'll see commonly, maybe cancer patients, or maybe, you know, there are reasons why they have those risk factors we talked about. These are patients who I'll just give them long term. It's better for them to have long term. And try to monitor bleeding. So these are examples of anticoagulant. As you can see, warfarin, the most common anticoagulant we have, and I think the cheapest, is the vitamin K epoxy reductase inhibitor. I think the challenge a lot of people do have with warfarin is because, you know, a lot of things, food, drug interaction with it, and also you have to do monitoring. I'm sure there are INR clinics over there. So there are INR clinics over there, and yeah, for the indirect thrombin inhibitors, the heparin, the low molecular weight heparin, and the fondaparinux. And then you have the direct oral anticoagulant, the DOACs. I think these are slightly more pricey, they're expensive, but once patient get access to these, I think it's more convenient for them because they don't have to do the INR clinic. They don't have to be, you know, to worry about if their diet can affect, you know. And at the bottom, if you look at the thrombolytics, we talked about it. What it does is it's all about clot busters. So what happens to patients who they've had a PE, you've treated them, and just with anticoagulation, and then now they're developing bleeding. So for patients who cannot tolerate anticoagulation, there's a role for IVC filters. So we say because most of the clot originate from, you know, the lower limbs. So it's reasonable to have a filter at the inferior vena cava, and sometimes it's not that effective, but if that's the only option you can do, then you can do that. And this is the IVC filter, as you can see. They put it at the IVC and just catches the clot. This is what you give to patients who cannot tolerate anticoagulation. So in conclusion, we've talked about massive PE. You have to rescue them with a clot buster. Either if there are other alternatives, and maybe if they have contraindication, maybe look at the catheter-directed therapies. For the intermediate high, you have to do a careful assessment to see how severe they are. And if they have all these signs of an organ injury, and they don't have, and they meet the criteria. They don't have anything to make them to have a contraindication to receive it. I think it's reasonable in a third world, or maybe in a resource-limited setting, to give them an option of systemic thrombolysis if they don't have either suction thrombectomy or anything like that. But regardless of whichever way you go about it, do not forget to start anticoagulation and to continue anticoagulation. Any question? Can you guys hear me?
Doctorku aad buu mahadsan yahay. Wax su'aala miyay jiraan before we move to the next session? Okay, wax su'aala ma jiraan. Thank you very much.
There's a question. There's a question. Go ahead.
Okay.
Thank you, Dr. Abdullahi Hussein, for the excellent presentation. Dr. Abdullahi he did internal medicine in the USA and then fellowship in critical care. One of my questions is here in Somaliland, Dr. Abdullahi, you know, we don't have anticoagulants. Most of the time, I think they may have heparin. What do you think about the role of heparin in Somaliland? The other question is, for the people who travel long distance like me, my flight is 16 hours, okay? What's your advice to prevent blood clot? Thank you.
Well, those are tough questions, and I think it's a question that all of us think about it every day. In Somaliland, I think first of all, I think with the heparin, because it's mostly IV, if there's the patient they have to go to the hospital, but there's the option of low molecular weight heparin. I don't know the availability there, but I think now with the brand names and the generic, there should be a way to have that organized. The reason I'm saying that is because myself, I grew up. I was born and I grew up in a resource limited settings, even here in Kenya, and for some reason in the last 10 or maybe 20 years, because of medication from drugs from in large scale production from India and other places, there's access, there's a way to find those medication, of course, in the proper channel, working with the ministry and everything there. I think there is, this is discussion that needs to be elevated to, of course, the government officials as well, the Ministry of Health of Somaliland, and to find ways, that they can bring the most common or maybe most needed medication into the country. And I know there's a lot of educated, wonderful people in Somaliland from different parts of the world and from Somaliland who train Somaliland themselves, who are at the board. And I think just like in any hospital settings or in any country, they can sit down and come with a common entry of medication. And the reason I'm saying is because a lot of time, we at least know of a family member or a friend who went to the hospital, was in shock. They couldn't explain why they were in shock. They were probably empirically covering with antibiotics and stuff, and then they just missed it. And especially now for the intermediate PEs and the low risk PEs, because you have more time to buy, and most of the facilities, even here in Kenya, in small hospitals, we don't have access to CAT scan. You have to be sent out to CAT scan and come back. And all you have is just chest X-ray. So most of them don't even think about it, and they don't have that in their differential. And I have a friend who they lost their mom. I have family members and friends who've been diagnosed with PE, and you just need to start looking for it. And at the same time, I understand these challenges because you have communicable diseases to take care of and stuff. But something like that, which can easily affect people, and once it happens, it's a killer. Because most of the time, when it happens in a high-risk patient, some of them don't even reach the hospital. It's done. But the ones who we can catch, at the intermediate and the low risk, we can do something about it so that they don't go there. Regarding long flights, that's a good question. I have to go and research more about it. But from what I've heard about my colleagues and friends, is that I think there are those like the SCDs, that the one we have at the hospitals in the state. There are those stockings people can wear, and also now people are more cognizant. You can see people at the plane, everybody being given opportunity to walk around and exercise and stuff. But I think just having that those particular special socks will help, especially if you're a frequent traveler, if you're a truck driver, if most of the time you spend more than 4 to 6 hours immobilized. Yeah. But otherwise, once again, I want to say congratulations, mashallah, for the people, for the new graduates. You have done the biggest part. I would say the most important thing is mentorship. Look for a mentor. Before, some of my colleagues who are there already, before they leave, make sure you take their contact, their email, and try to work as a group. I know there are a lot of people without much resources, but now with the internet age, I remember more than 10 years ago, a friend was telling me, though Africa is lagging behind, now the equalizer, the thing which will bring the world almost on similar platform, is the internet age. If you have access to internet and you have your small laptop, you're good to go. Because many years ago, people used to buy expensive books. They used to pay expensive tuition to make sure they attend a class. But now, from the comfort of your home, from wherever you are, you can sit down with your internet. And even now, for the people who are interested to doing the USMLE pathway, you can be joining groups online for the USMLE. You see them even sharing their resources, their scores, how long they studied. They study for 3-6 months. Some of them, they have kids, right? Some of them, they have kids. And some of them have access to the PDF and the books. And you can do it right from there. And instead of going all the way to the state to do the exam, you can fly here to Nairobi. And the reason why I know that is because my first time I did my exam here in Nairobi, I met one of the ladies. She flew all the way from Djibouti, and she was doing her second exam. And actually, she was the one who was mentoring me, and now, mashallah, she's finishing her fellowship in critical care in the States. And she was able to be given a visa to go there with her kids, I think like 2 or 3 kids. So it's manageable. It's doable. People ahead of you have done it. And you guys can do it.
Thank you very much. Aad iyo aad baad umahadsan tahay, Doctore. And any other question? Okay, and we will move to the second lecture. Waxaa inoo diyaaraa Dr. Ibrahim Sultan Abdullahi. Soo dhawow.
Assalamu alaikum.
Assalamu alaikum. Let me see if I can share my screen here for a second. Let me put this one first.
Dr. Ibrahim wuxuu
Okay.
ku takhasusay xanuunada sanbabada waana Professor Associate University of Tennessee halkan uu inagu soo booqday jaamacaddeenana kolley tiim badan oo wax u dhigay ayaa laga yaabaa inay halkan fadhiyaan marka isaguna insha allah tacaala waxa uu inoogu bilaabi doonaa basics of pulmonary function test soo dhawow Dr. Ibrahim.
Let me see if I can get this out. Give me a second. Let me see if I can just share the screen here for a second.
Okay.
Second. Give me 1 minute. Yeah. All right. Can you see the presentation now? Can you hear me? Hello?
Yes, Doctor, we can see. I can see, Doctor.
Waxaan ku maqlaynaa slides-kana waan arkaynaa.
Okay.
Soo dhawow.
All right. Thank you. Thank you. Subax wanaagsan. It is truly a pleasure to join you this morning, Dr. Yusuf and others, Dr. Hussein, all of you. Subax wanaagsan. waxaan ka jeclaan lahaa anigoo maanta shaah idinla cabaya laakiin insha Allah bin Rahman next time. Marka maanta waxaan ka hadlaynaa basic of pulmonary function test interpretation. This is the first lecture. Marka this is the outline we will follow inshallah. We do a little bit of introduction. Ka hadlayno waxaan u isticmaalo BFT-ga iyo normal value ama marka also waxaan ka hadlaynaa ama component ama qaybaha pulmonary function test-ka oo ay u kala qaybsan saddexda qaybood spirometry iyo lung volume iyo DLCO. marka waxa haddii waqtigu inoo saamaxo waa inta ugu dambaysa waxaan ka shaqeynaynaa cases baan haddii la yidhi si aynu u highlight garayno waxyaabihiinu ka hadalay insha Allah. waxaan ku bilaabayaa case-ka ugu horeeyo. This is a 23-year-old woman. She presents with complaint of shortness of breath and chest tightness. Ma neefsan karayso, naqaskuna wuu ku adag yahay. The symptoms has been she had began ama ay bilaabmeen mar ay ubax ursatay oo ay roomkeeda dhigtay. There is a fever, cough, and other complaints. Physical exam ama markii aad eegtay waxay leedahay shahaad tachycardia, wadnaheedu wuu garaacmaya, aad bay u neefsanaysaa, wheezingna waa leedahay ama throughout the chest. The rest of the physical exam is halkan waxay leedahay big expiratory flow. We will talk about that, but it's just like the big expiratory flow is decreased. We'll talk about that in later. So gabadhan naqasku hayo naqasku hayntu oo bilaabmay marka ay ubaxa ursatay ama gurigeeda dhigtay sideebaad maxaad u samayn karaysaa yani which of the following tests would be help you make a diagnosis either bronchial challenging test, blood test, pulmonary function test, chest imaging, and skin test. So gabadhan naqasku hayo cannot breathe, she has tachycardic, she's wheezing. So most likely she has asthma or acute asthma attack. So the next test we probably will do is a pulmonary function test to see if she has obstructions or no. I think all the other tests is most likely will be normal. Asthma is one of these diseases that pulmonary function tests are useful, especially when they are having attacks. The second case is a 54-year-old man with active smoker. He smokes about 1 to 2 packs per day in the last 35 years. So he has about 75 pack years history of smoking. He presents with shortness of breath, which worsens with activity the last several weeks. 2 months ago, he had bad chest pain. So pay attention to that, bad chest pain. And whenever you are taking a test, everything they say is important. So you're thinking about, okay, what's the chest pain have to do with his shortness of breath? He's also reporting swelling of the legs. So you have a chest pain, you have a swelling of the legs, you have shortness of breath, and you're trying to figure out, okay, what do they do to have to do with each other? So think about that case. We'll come back to this. So again, I'm talking about the chest. When you're using, why we use a pulmonary function test, we use to evaluate a patient who are symptomatic, meaning like the people we talk about, like people who are short of breath, okay, like we just talked about. People who are having a cough, people having chest abnormal chest X-ray. We use sometimes to do a lung function screening test, like people who are joining, for example, military or something like that. We use the PFT to quantify disease like asthma, like COPD, like interstitial lung disease, like neuromuscular and chest wall disease. So pulmonary function test is really very, very helpful diagnostic tool. We use it to evaluate for preoperative assessment, like if patients especially are going through a cardiopulmonary surgery. We use it to monitor a pulmonary drug toxicity. There are medications that affect your lungs. So before we start those medications, we do a pulmonary function test, and then we follow them and to see how that affects them. So today I want you to really have a good understanding of components of pulmonary function test, particularly the spirometry, which is the most important part of the pulmonary function test. We use it before bronchodilators and after bronchodilators. The other component is the lung volume and what we call the diffusing capacity of carbon monoxide or DLCO. So 3 components: spirometry, lung volume, DLCO. What's the most important one? Is spirometry, okay? So we'll talk about this in details. So spirometry, as I said, is the most common pulmonary function test. It's almost like becoming an EKG. It's almost in every primary care office in the United States. It is almost in every hospital. It's our bread and butter. Like cardiologists have the echo or the EKGs. We have the chest X-ray and BFTs. So that is really becoming a very, very common. But it's not only becoming a pulmonologist tool, but it's becoming a primary care tool. Or it's becoming a very useful test. It measures 3 things: FVC, which stands force vital capacity. Okay, and FFE1, which is forced expiratory volume in the first 1 second. I will explain all of this. So I just want you to understand right now, it measures only 2 things. And then you can calculate the third thing, which is the ratio of those 2 things that you measure. Okay? So these 3 things, forced vital capacity, FFE1, and the ratio is the most important. Okay. All right. So again, it's useful for diagnosing obstructive lung disease, for example, COPD, asthma. It's useful for monitoring lung diseases, like we talk about. So normally, lung function, is distributed, and most of the people fall in the middle. Okay, so anywhere from 1.5 to almost to 3. Anything outside of that is, let me say, this is like below the 5th percentile. Above like 2.5 is higher the 95 percentile. So majority of the people fall in this range. So you will see the people when they hear below the 5th percentile of normal, they are talking about here. So if they are -2, -4, -5, that means they have a low lung volume. If they are on this side, on the positive side, they are above normal. So just especially particularly pay to the low normal. This might not be as important yet, but this is right now we are migrating to start using C-scores to quantify severity. So that's, I'm just introducing you to this, but I will let you know what we currently use. So that's why I show you this with quantified severity of a lung function. So if you are in the falling into minus 1.5 to 2 is mild. If you are around here, is moderate. If you are here, you are severe. So that's what it means. The more negative you are, the lower you are, or more severe you are. So anyway, actually, this might be, I should have the, so again, remember I show you the ratio of, you measure the forced vital capacity, you measure forced expiratory volume, and you check the ratio. If the ratio is less than 70%, then you have obstruction. If you have more than 70%, then you are normal. So if you have an obstruction, then you quantify the obstruction in 2 ways. One way is the so-called C-score, which is this way. But another way to quantify, which is the mostly that we have been using in the past, and the gold still uses it, is this way. If you're if FFE1 is more than 80%, then you are mild. If it's between 50 and 80 is moderate. If you are less than 30, then you are severe. If you are between 30 and 50, you are severe. If you are less than 30, you are very severe. I will tell you easier way to remember. If you have less than 1/3 of what you're supposed to have, you are very severe. If you are less than 50%, half of what you're supposed to have, you are severe. If you are between 50 and 80, you are moderate. If you are more than 80%, then you are mild. So again, if you get on the exam more than 80, you are doing okay. If you are between 50 and 80, you might be getting a C or something like that. But if you are, less than 50%, you are in trouble. You are very severe. And if you are less than 1/3 what you're supposed to have, then you are very, very severe. So again, these are a way to quantify obstruction. How do you define obstruction? By knowing the ratio, and what the ratio is less than 70%. Okay, so is your ratio less than 70%? Yes, that you have obstruction. And then if you have obstruction, how bad is the obstruction? You quantify in 2 ways, by either C-score or FFE1. Is your FFE1 more than 80%, is you are mild. If your FFE1 is less than 30%, then you are very severe. So you want to know, okay, does this patient have obstruction? Yes or no? Okay, you said he has an obstruction. Okay, then how bad is the obstruction? You quantify by using either C-score or the FFE1. Okay. All right, so what determines the normal value of pulmonary function test? Usually age. And we'll talk about that a little bit more, maybe in the next lecture. So age, usually as you get older and get up to your 20s and mid-20s, your lung function increases. But when you have in your mid-20s and 30s, your lung volumes plateau. And then after 30s, mostly downhill. Okay, so it goes down. So age, biological sex, usually males have a more lung volume than the females. Height, how tall you are, you might have a more lung volume. Race and ethnicity is also come into play because there are different proportions of chest size and legs in a different racial ethnicities. So this is a little bit, just I really want you to stay with me and try to understand this. When you take you have in our lungs, we have different compartments and different value. Okay, so when you take a full deep breath and fill your lungs up, I want every one of you sitting there, take a deep breath with me. Fill that lung up. When you fill that lung up, that's what we call total lung capacity. That means this is how much air you have. Okay, and this much air is made in a different components. Okay, okay, let's take a deep breath again. Fill it up, lung. Then breathe out as much as you can. Breathe it out. When you breathe out, you breathe it out what we call vital capacity or forced vital capacity. So, but when you breathe out and you breathe out as much as you can, okay, until you could not do it anymore, okay, you still have some air in the lung. Okay, that's what we call the residual volume. This is this part. This part never comes out of the lung. Okay, so that's why the lung doesn't collapse completely. Okay, that keeps it up. Okay, so residual volume. So the total lung capacity is made of vital capacity plus the residual volume. Okay, all right. Tidal volume, when you are sitting there and you're breathing and you're not, you are not trying to push air in and out. You can see when you try to breathe in and then you breathe out, you get more air out, in and out. But when you are just sitting there, I'm breathing comfortably, you do what we call tidal volume. Tidal volume, and usually that's a very small amount. Okay, this functional residual capacity, inspiratory capacity, these are different volumes in the lungs. But the most important ones I want you to understand is the residual volume, TLC, total lung capacity that you can, when you fill, that's how much air your lung can carry. And then vital capacity, or sometimes we call forced vital capacity, how much air can you get out of you? So when we are doing this test, we were looking at saying, how much air can the lung get in, how much can it get out, and also how efficient can it get out. And I'll talk about that. I want you to remember those three things. How much air can it get in, how much air can it get out, and how efficient is it doing that. Those are, again, those are the three most important thing that I want you to understand. Okay, all right. And by looking at this value, you can tell, because we know what normal value should be. So when you test that and see how those values compared to normal one, then you can tell, okay, this person is getting in what he's supposed to, he's getting out what he's supposed to, so he's okay. Or the other way around, he's not breathing in enough, he's not breathing out enough, or efficiently, like that. Okay. So, and this is the residual volume. I tell you that that's the volume that you cannot get. And the other thing I want you to see, there's a up here capacity C, total lung capacity, forced vital capacity, functional residual capacity, inspiratory capacity. Their capacities are usually two values or more together. Okay, you can see a total lung capacity, you can say it's the vital capacity plus the residual volume together. It's the whole lung. Residual volume is functional residual capacity is a residual volume and expiratory residual volume to put it together. So capacities usually are more than two volumes to put together, but volumes are individual volumes. Okay. So I was telling you, normally when you are sitting there and you are not in stress, you are breathing tidal volume, it's usually small amount. But all of a sudden, if you run, you are chased by a lion, or you are, you are running upstairs, more likely, then you start breathing faster. So you increase how much air you can get in and out. Okay. So when we are just sitting there, we have a lot of what we call reserve. That's what's called functional residual capacity. So you increase how much air you can get in and out. But after a while, you can get tired. So this is what I was telling you about. So when you are, let's say this is the age, when you are young, your lung volumes goes up, like it kind of plateaus up in late 20s, okay? And then from there on, it just goes down slowly. You might be losing about, 30 cc of lung volume every year, okay? But, and if you smoke, maybe actually faster or so. We'll talk about that later. But there are some things that can affect the lung growth, usually like if the child is malnourished or malnutrition or exposed to toxins and things like that, the lung might not grow as well as it would. And they end up with a low volume compared to otherwise. And that's called, and that can lead to a premature death because, again, that's a problem. So this is right now has been recognized is the development of the lung. It can be affected in early parts. Okay, so just understand what I want you to take this from it is that the lungs volumes increase and they plateau in the late 20s, but that lung growth can be affected by multiple things, like premature birth, by toxicity exposed to when the child is young, all of that. It also can be affected, how well you deteriorate it can be affected by toxins that you expose to yourself later on. All right. So I said spirometry is the most important thing. And if you have to understand one thing today from this lecture, I want you to understand spirometry. Because it is easy, it's available, and it's very, very useful. It's something we use it every single day in our clinics. So spirometry is what it tests, like I talk about, forced vital capacity, like that air. Okay, let's take a deep breath in again. All the way, and then breathe as much as you can out, as fast as you can. Okay. So breathe out. So it's measuring is that when you fill your lungs up, you might fill it up to like about 4 or 5 liters, okay? And then you breathe out as fast as you can, as long as you can. And we are measuring how much you can get it out. So you might be able to get it out. This one able to get out maybe about 5 liters out, getting about 5 liters out, okay? This person was when you take a deep breath and then breathe out as much as you can, as long as you can. You have to breathe at least 6 seconds, okay? All right, so breathe out as fast, as long as you can. See how much air you can get out. So this person was able to get out 5 liters, okay? And the most important thing is, I want you to understand, was able to get out 4 liters of the 5 liters in first 1 second. Okay, so let's do it again. Take a deep breath. Breathe out as fast as you can. Keep breathing, keep breathing, keep breathing, keep breathing, keep breathing, keep breathing. Okay, so if your lung is working the way it's supposed to, okay, you're supposed to get more than 80% of the air in the first 1 second. Okay, so what does that mean? Although you have 6 seconds, you get most of the air out in the first 1 second. What does that mean? If you have to breathe faster, instead of breathing 6 seconds, maybe you have to breathe every 2 seconds because you're running, you are doing something like that. You can still maintain it and you can still breathe. That's what it means. So when we are doing this test, we want to know how much air you can get out and how efficient you can get out. Okay. Look at this. But look at this person here. When we tell him to take a deep breath and breathe out as fast as you can, as forceful as you can, okay? What we call it, a fast and furious, okay? Okay, we call that. This person was able to get out only 3.22 liters, okay? But not only that, in the first 1 second, he was able to get out, maybe about 50%, 56%. Remember I said, if that ratio is less than 70%, is obstruction. That means your lung is not getting out the air as efficient as it's supposed to. All right? So please keep that in mind. So this person has obstruction. Okay, if we want to find out how bad of obstruction is, we have to know what's the ratio of the FFU1 compared to expected. Okay, so if it's more than 80%, it's mild. If it's less than 30%, then that's very severe. If it's in between those, then it is severe or moderate. Okay, all right. So those are the most important thing. Again, spirometry is the most important thing. Spirometry measures what? Force vital capacity. How fast can you, how much air you can breathe out, okay? And FFU1, how fast you can breathe out, okay? And there's the ratio tells you how efficient that you are, okay? So that's the key thing. So are we saying that, can you, so that's what I want you to understand, okay? Look at this other one. Okay, so now same person, we're expecting to do this, supposed to breathe like 5 liters out total, get the first 1 second, 4 liters out or 80%, okay? So he doesn't have obstruction when it's normal, okay? But look at this one. What this person does is he breathes out less, 3.5 liters instead of 5 liters, so it's less. But most of it he gets out in the first 1 second. So this guy is even more efficient than normal person. Okay, so 91%. So what does this say? This person cannot get that much air out, but whatever little air he can get out, he can get it out fast. So what this means is that this lung is adapted to getting small air in, but still trying to make the best of it and get it out more faster. So this is more like what we call interstitial lung disease. Okay, what that means is that the lung is fibrotic. It cannot take much air, but it can get the air out quicker. Okay, so that's why spirometry is very, very useful. I want you to take this, understand. It can differentiate obstructive lung disease versus interstitial lung disease, which are the most common causes of lung diseases. Okay, so if you want to understand what making this guy short of breath, and you're trying to figure out, is it from his lung? Is it his heart? You have to check if his lungs, okay. Is the lung getting the air in? Is the lung getting the air out? Is the lung getting the air into the blood? Okay, we'll talk about that component 3 things, but that's the 3 things that you want to know if the lung is working. Is the lung getting air in? Is the lung getting air out? Is it efficient? And is it transmitting the air to the blood? So those are the function of the lungs. Okay, and spirometry and pulmonary function test to test all these components. That's why it's very, very useful. So if you spend a little bit of time understanding, I think it's worth your effort. Okay, so I really, as I said, I want to spend a little bit more time on that spirometry because I want you to understand spirometry is the most important. It's the easiest, it's the simplest, and it's a small machine. Right now, you can put it in your office and you can transport it everywhere. And you can get a lot of most useful information of the lung function. Because again, that's what you want to try to assess. What is the lung function? How is the lung functioning? Is the lung getting air in, out? Is it efficient? And is it able to transmit it? Okay, so what is the spirometry? It measures again, forced vital capacity, FFU1, and the ratio of those 2. And if the ratio is the most important thing, if the ratio is less than 70%, you have obstruction. If the ratio is not normal or more than 70%, you don't have obstruction. And then the second thing is you look at your FVC. If your FVC is normal, okay, then you have enough volume as well, okay? So you don't have a low volume. So you don't have obstruction and you don't have a reduced volume, and you can say your lung function is normal. You're getting air in, you're getting air out, okay? You might not be able to transmit the air, so the lung gets the air in, it gets it out, but also gets the air in and transmit the oxygen to the blood. So that's a third component. So getting air in, getting air out, and transmit the oxygen to the blood, okay? So the spirometry is very good about telling you how much air is getting in, how efficient they are getting it out, and then I will talk about how you determine if the oxygen getting into the blood again. Okay, all right, so forced vital capacity, FFU1, the ratio. Is the ratio less than 70%? You have obstruction, okay? If you don't have obstruction, then you look at the FVC. If the FVC is normal, then you can say this spirometry is normal. There's no obstruction. There is no reduced volume. Therefore, spirometry is normal. And this lung is getting enough air in and it's getting out efficiently. I hope that's understood. Okay, because I want to repeat that several times because I want to make sure that's to be understood. All right, so the second component is the lung volume. Okay, lung volume is useful when spirometry is show reduced forced vital capacity. Because if your forced vital capacity is normal, then you don't even have to do the lung volume. You know the lung is getting enough air in and out. Because when I take a forced vital capacity like this, and that's normal, then I know the lung is getting enough air in and enough air out. So I don't even have to do the lung volume anymore. Okay. So, but if the FVC is abnormal or when I'm not getting enough air out, if I'm not getting enough air out, that means I'm not getting enough air in. Okay. All right. Hello. Somebody's interrupting.
كده شيخو كده عبد المجيد.
The ways to measure the lung volume, there's several ways to measure, but the most common one is that one I start is pulsimeter. Lung volume is also difficult to measure. You know, you have to have almost this room big box, things like that. So that's why we really don't do it as much. This is radio X-ray, just telling it just normal X-ray looks like this. Okay, people who have obstruction, what that means is they get the air in, but they cannot get out. So their lungs become expanded. Okay, so what we call hyperinflation. Okay, so they become big lungs. Okay, the people who have people who have a restrictive lung disease, their lungs fibrotic and they get small lungs. Okay, so by just looking at the X-ray, you can get an idea. Oh, okay, this guy's hyperinflated. This has a low lung volume. So it will give you an idea. And sometimes you even do CT scan, you measure it in different segments, you come a value, and you can say normal value, not value. Normally, we don't do that. Again, we use the spirometry the more than anything else. Okay, so far I said we do spirometry. If the spirometry is normal, that means forced vital capacity is normal, FFE is normal, ratio is normal. Okay, then you don't really have to do anymore. You say this lung is getting air in and getting air out. Okay. If the ratio is abnormal, that means less than 70%, then you have obstruction. If the ratio is normal, then you look at the FVC, and if the FVC is normal, then most likely you don't have restriction. But if the FVC is abnormal, then you might have restriction and you have to do lung volume. Okay. What are things that diseases can cause obstruction, which are asthma, COPD? What are diseases cause reduced forced vital capacity or reduced lung volumes? Interstitial lung disease are the most common ones. Lung volume, like again, spirometry measure two things, and then we do a ratio of those three things. Okay, lung volume. Most important thing is usually total lung volume. That's the most important thing. You can look at the residual volume, you can look at the functional residual capacity, but usually a total lung capacity is the most useful. These lung volumes is the same when I talk about it. You know, the total lung capacity is the total lung and the volume in the lung. And these are the different volumes we talk about earlier on: residual volume, functional residual capacity, inspiratory capacity. And you can look at it on your own time and to understand. Residual volume is the volume that never come in. Forced vital capacity is that air we can get it in and out if we have to. Okay. Tidal volume is that normal breathing that we're doing now when we're sitting comfortably. Okay. All right. Again, this is something I would just spend a little bit of time, really try to understand the lung volumes. We talk about lung volumes usually 80% to 120 total lung is normal. So when you do a lung volume, you look at the TLCO and see if it's less than 80%, then it's abnormal, it's reduced. Okay. Most of the time, you're really not going to see anybody have more than 120% unless they have a severe obstruction. If you see between 80 and 120 as in the normal range. So if TLCO is less than 80%, then we say, okay, it's abnormal. DLCO, we'll talk about it in a later. The residual volume, we talk about functional residual volume, we also talk about. So this one good thing about it is they are between 80 and 120, you know, they are mostly in their normal range. DLCO goes down to about 60%. All right, so we talk about the lung volume. We talk about the spirometry. We talk about, okay? And again, I said spirometry is the most important thing. I want to repeat myself. And you measure forced vital capacity, FFE1, and the ratio of those. Those are the three things. And lung volume, you measure, most important thing is the total lung capacity, TLCO, okay? And now I'll talk about the DLCO. So this is what I call the fabulous five, okay? Okay, And those five, well, forced vital capacity, FFV1, the ratio, TLCO, or the total lung capacity, and then DLCO, and we'll just talk about that in a minute, okay? And those five, the three are most important is the spirometry, okay? And those three, even the FFV1 and FVC ratio is the most important one because it tells you if there's obstruction or not, okay? All right, so fabulous 5, magnificent 3, all right? All right. Single breath carbon monoxide diffuse capacity. So we let the people breathe a very small, tiny amount of carbon monoxide, and then we measure how well that transmits to the lung. So we measure how much we gave it to them, and then we see how much comes out, and then we know how much went into the blood. Because if we know how much went in, and then how much come out when we test their breath, okay, then we know how much went into the blood. So we know how efficient. So if let's say they breathe in a little bit of carbon dioxide and all of it went into the blood, we know that 100% went into the blood. So the lung is transmitting very well. But if nothing went into the, all of it came out, then we know it hasn't transmitted anything. So we know that lung is not transmitting what it's supposed to transmit. Okay. The lung function, so you're getting how much air you're getting in, how much you're getting it out, and how well you're transmitting it to the blood. All right, this is one thing I love about the pulmonary function test because it tests the integrity and how well the lungs working and or where the problem is. Is it not getting enough air in, not getting enough air out? Is it not transmitting into the blood? So that's beautiful. Okay. It's most useful, you know, for obstructive lung diseases like COPD or asthma. It can differentiate COPD and asthma because COPD, it destroys the lung. So asthma usually in between attacks, the lungs are normal. So their DLCO is normal. If there's an obstruction and the DLCO is normal, it's most likely asthma. If there's obstruction and DLCO is abnormal, it's most likely COPD. You know, see how it's useful it is. It's also is useful for the restrictive lung disease, okay? So if your spirometry is abnormal, forced vital capacity is reduced, and then you check the TLCO is reduced, that is the lung fibrotic lung, that's an interstitial lung disease, okay? And then you check the DLCO, okay? If the DLCO is normal, then look like the lung is transmitting the oxygen, so the lung is normal, there's something's restricting, so it's the extrinsic interstitial lung disease, okay? It's the extrinsic component, okay? There's like kyphosis, there's some structure abnormality of the skeleton, something like that. Maybe the patient is very obese, okay? But if the DLCO is abnormal, then maybe he's interstitial lung disease or intrinsic lung disease, like pulmonary fibrosis. So this is really, really very helpful. Sometimes, let's say spirometry is normal, lung volume is normal. The only thing is abnormal is a DLCO. Then that might point out to a pulmonary vascular disease like pulmonary embolism, like Dr. Hussein was talking about a minute ago. So this is a very, very useful test. So DLCO measures how well that air you breathe in, that oxygen that you have taken in gets into the blood. So the air comes in, oxygen full with oxygen when you take a breath goes to the alveoli, and then oxygen goes into the blood, and then carbon dioxide comes in. So when you are measuring DLCO, you're measuring how well that oxygen goes into the blood and how well that connection between the alveoli full of oxygen and the capillary full of blood, okay, how well that they are touching each other, how close they are together. There's no disease in between, okay, because if there's a disease in between, then the oxygen is not going to the blood, okay? So that's fantastic. All right. So the diseases that cause decreased DLCO, decreased alveolar capillary membrane. this is the connection between the blood and the alveolar capillary membrane interface, okay? So decrease that. What it decreases that, okay? For example, if you had a PE, if you had a PE that's blocking here and there's no blood going through it, then that's decreased. If you have something that's filling this alveolar, like pneumonia, like fluid, like heart failure, okay, then that interface is decreased. So anything like that, increase the thickness with separating the two, okay, something getting in between, like pulmonary edema or something like that, pulmonary hypertension, anemia, and things like that. So things that increase it, usually is a pulmonary hemorrhage. This is usually you don't see that as much, but sometimes obesity and asthma in mechanism we don't understand it fully can increase DLCO. So if you see increase DLCO, think about those most likely. Okay. All right. So what I want to do in the next few minutes, and Dr. Yusuf will tell me when I'm running out of time. So you want, when you do the spirometry, you want to say first, is this normal or abnormal? Again, because we know the value, what normal person in that age group value should be. Okay, we know that. Okay, if you are a male, 50 years old, this tall, this is your normal value should be. You have charts. Okay, so all of that is known. So you compare that to the measurement that you get. So if it's not normal, okay, do you have obstruction? Okay, is your FFE1 FVC ratio less than 70%? Yes or no? Okay. If you don't have obstruction, you have a restriction. What's your FVC? If your FVC is less than 80%, then you have a you might have a restriction. You have to do the TLCO to confirm that. Okay. And then, do you have a vascular disease? Is your PFT is normal? Spirometry is normal. And then only things abnormal is a DLCO. Then you might have pulmonary vascular disease. So you look at the pattern, or you might have a neuromuscular disease. Okay, we'll talk about that. Okay. All right. So let's look at this person. Okay, we say 40-year-old. I think this is the guy we started with the lecture. He's an active smoker. He has been smoking and he has like about 75 back years. He's short of breath. It's worse with activity. Happened 2 months ago. He has a chest pain that went away slowly. He is reporting a leg swelling. Remember I said shortness of breath, chest pain, leg swelling. You know, just thinking about, okay, what do they have to, how they connect. So you're asking, is the BFT is normal or abnormal? What type? If it's abnormal, what type of abnormality you have? What's the pattern of abnormality? And then how bad if the abnormality is, and what's the likely diagnosis? You get all of these things from the pulmonary function test. So this is his pulmonary function test. So this is what I was telling you. You have a what's called predicted. This is, we know this is a 54-year-old man. We usually know what their weight and their height. And if you put those in, then this is the computer will tell you, this is what you should expect. So remember, these are the three most important one I said. The ratio is the most important, okay? This ratio is 78%, is normal. It's more than 70%. Then you look at the forced vital capacity, is 4.23 is expected. And he had actually 4.39. So actually 100%, 102%, that's normal. So he does not have obstruction. He does not have a restriction. So spirometry is normal. Okay, if you want to go down and look at it, the DLCO is 80%, 84%, it's normal. So no obstruction, no restriction, and DLCO is normal. This man is getting air in, is getting air out efficiently, and is transmitting that oxygen to the blood. His lung is okay. It's not his lung. Okay. So if it's not his lung, where is it at? So we said that there's no, so does he have a COPD? Does he have asthma? Does he have a congestive heart failure? Does he have interstitial lung disease? So remember, he doesn't have a COPD, he doesn't have obstruction, he doesn't have asthma, he doesn't have obstruction, he doesn't have a reduced lung volume, so he doesn't have interstitial lung disease, he has a congestive heart failure. So that's why he had an MI two months ago. He developed a heart failure, that's why his legs were swelling, and that's why he's short of breath. Okay. Sometimes congestive heart failure can reduce your DLCO, especially if you develop a large pulmonary edema. But in the mild congestive heart failure, DLCO could be still normal because there's a range. But this is most likely what this person had, and that's why he's short of breath, because he had an MI. Okay. I'm gonna just do cases until Dr. Yusuf tell me it's time. So look at this guy. He's a 58 years old smoker with a chronic morning cough. Okay, so you do spirometry. Spirometry is for ratio is normal, which is the most important thing. And that's the way you look at the first. Is my ratio normal? Yes or no? Ratio is normal. Okay, and then I look at the FEC, and FEC is also normal. Okay, so it's good. So far, so good. If your FEC is normal, you really don't even have to do the TLC, but you did TLC also confirms that's normal. You look at the DLCO, it's normal. So everything is normal value. Okay, so this person is normal pulmonary function. Okay, so you look at this 35-year-old male. He has a nocturnal early morning cough. He's short of breath. So you look at this spirometry, the ratio is less than 70%. So it's abnormal, telling you there's obstruction. Okay. And then, okay, if there's an obstruction, then you look at the TLC, or even you look at the you have obstruction, and then you're trying to figure out, is this asthma? Is this COPD? Then you look at the DLCO, and the DLCO is normal. So if the DLC is normal, what that tells you that interface between the capillary and alveolar is intact. Okay, so this is more like asthma, like and then you do a bronchodilation to confirm that, and you see that the obstruction went away. And now the ratio is normal. Okay, so this is consistent with asthma that improves. Actually, this should be in line now. They changed this one to a 12%. But asthma, this is consistent with asthma. It is pre-bronchodilator show obstruction. Post-bronchodilator, that obstruction improve. That is, and DLCO is normal. That's consistent with asthma. This is how spirometry is very useful to help you figure out why a person is short of breath. 88-year-old male smoker who recently returned from China and developed a shortness of breath. His ratio is normal, and then he doesn't have obstruction. And then his FVC, his forced vital capacity, is also normal. And then so say, okay, he doesn't have obstruction, he doesn't have a reduction. So why is he short of breath? You look at the DLCO, okay, and DLCO is low. So you suspect maybe this is a pulmonary vascular disease then. So pulmonary vascular disease. That's what Dr. Hussain was worried about. If this guy came from all the way from China, he had a DVT and a PE. All right. So look at this other one. 55-year-old African-American male smoker with cough more than 2 years duration. Okay. So you look at the ratio. Whoa, this guy is 89, 98%. Man, this guy is getting air out. Very efficient, getting air out quickly. Whoa. But you look at the FEC, and FEC is reduced. So this guy is taking small amount of air, but it's getting everything he got out quickly. Okay. So, okay. So now because FEC is low, or forced vital capacity is low, this is supposed to be FFU1 here, so that's a mistake. So this is the FVC. and the FVC is low, then you did the TLC, and then TLC is low. Okay, so you know there's a reduced lung volume. Okay, you have a reduced lung volume. Okay, and then the next testing you do is to do the DLCO, and the DLCO is reduced. So you have somebody who's getting very small amount of air, and not only that, but whatever air is coming in is not transmitting the oxygen. So that interface between the lung alveolar and the capillary is blocked. So there is a fibrosis, and that fibrosis is allowing you not to take enough air. And not only that, but it's not allowing you to transmit the oxygen to the blood vessels. So that you can see why that person's hypoxia is not taking enough air. And whatever air coming in, how much oxygen it has, is not transmitting it. Okay, so that is consistent interstitial lung disease, intrinsic interstitial lung disease, pulmonary fibrosis in particular. Look at this one. 60-year-old heavy active smoker with chronic cough. Again, you look at the say, okay, is there obstruction? You look at the ratio. Yes, there's obstruction. It's less than 70%. Okay, and then you look at the FVC. Okay, and it says it's 2 liters. It's low. And you look at the DLCO, abnormal. It's obstructive, and most likely a COPD. 68-year-old male with morbid obesity. Okay, again, the ratio is borderline. Okay, and you can say it's not less than 70%. But TLCO is reduced. Okay, but the DLCO is not reduced. Okay, so it's a restriction, but the DLCO is normal, though this most likely a extraparenchymal restriction, like the obesity. This guy must be like 500 pounds or like 200 kilos. So that all that weight is restricting his lung. Okay, but whatever the lung inside is normal and it's transmitting oxygen. Okay, so that's what it says. All right, so again, what we say, when you look at the spirometry, when you look at the lung function, you say, is it abnormal or is it normal or abnormal? Okay, and then you say, if it's abnormal, what type of abnormality is there? Is there obstruction? Is there a restriction? Is the DLCO is normal? Okay, and then if it is, you say there's abnormal, and then you say how severe it is. You look at the if it's obstruction, you look at the FFU1, and the FFU1 is more than 80%, it's mild. If it's less than 1/3, then you know it's very severe. Okay, and then in between is between those two. Okay, if it's 50 and 80, it's moderate. If it's 30 and 50, then it's severe. So you quantify it that way. Okay, and then you say, okay, you put all, and then what's the DLCO, and then you put all of those together and say, what is the likely diagnosis of this person's lung disease? So this is a busy chart, and I want you to spend some time on it on your own time and see if you can walk through it. You do the spirometry. If the spirometry show obstruction, then you have obstruction. You do the bronchodilation. If you respond to bronchodilation, it's most likely asthma. If it doesn't do to bronchodilation, you look at the DLCO. If the DLCO is abnormal, okay, that's most likely emphysema and COPD. Okay, all right. So let's say if the spirometry is show the ratio is normal, but forced vital capacity is low. So is there a restriction? You do the lung volume and you confirm it. Yes, you confirm it. Then you say, look at the DLCO. If the DLCO is low, then it's most likely intrinsic interstitial lung disease. If the DLCO is normal, it's most likely chest wall or muscular disease, like a lot of a neuromuscular disease, okay, cause a restriction because the person doesn't have the strength to take a deep breath, okay? So that is, that's how you determine that. If the spirometry is normal, okay, completely normal, then you may have to check the DLCO. If the DLCO is low, then maybe a pulmonary vascular disease, like that case I show you a PE, okay? So if a patient is, if the spirometry is normal, sometimes we do like what we call bronchial challenge, okay, to see if because asthma, if the patient is between attacks, like then it's normal. But if you do challenge, then you can make the asthma asthma come on. And when that asthma come on, you can see the lung volume reduce. Okay, and then you can diagnose it that way. So I think with that, I think I want to stop. And if there's a time, we'll take questions. If there's no time, then we'll go on the next. But I'll hand it to Yusuf.
mahadsanid Dr. Ibrahim, jazaak Allah khair. Cashar aad iyo aad u fiican buu ahaa. Runtii xanuunada sambabada dalkeena way horena way joogeen oo dee TB-da oo kale waa xanuun taariikhiya runtii oo dadka Soomaalida aad ula xidhiidha. Iminka xanuunadan kale ee iyaguna runtii way soo bateen oo iminka xiiqda oo kale si aanay dalkeena u jiri jirin bay u jirtaa. Marka waa waqti aad iyo aad u habboon runtii in maaragtay arrimahan laga hadlo. Waxaa jira iyaguna dee sigaarkii haddii ay beedmaayo waxyaabaalihii kale ee maaragtay hawada wasakhaynaya iyaguna aad u fara badan oo iminka xanuunada COPD-ga in general ay dalkeena aad iyo aad ugu soo bateen. Marka halkan runtii residentkii baa inala jooga, kuwii haddii ay beedmaayo qaybta TB-da joogay baa inala jooga, dhakhaatiirtii kale baa inala jooga. Marka haddii ay su'aalo maaragtay qabaan ama ay wax ku darayaan, aad iyo aad baynu usoo dhaweynaynaa insha Allah waqti yar oo kooban intaynaan lecture-ka labaad Dr. Ibrahim aanu inoo sii wadin haddii ay beedmo insha Allah.
And Yusuf, inshallah, waxaan doonaynaa bal inaynu haddii alla yari la iskaashado oo bal sidii aynu inshallah bidni raxmaan yani weliba khaasatan spirometry is very doable to put it in everywhere. So inshallah, but we need to inshallah try to see if we can collaborate. Maybe we'll work with SAHA, we'll work with other organizations and with you and see how we can make this test available almost in every hospital in inshallah bidni rahman. I think that's the next inshallah next few years. That's our hope and prayer.
Assalamu alaikum warahmatullahi wabarakatuh. Thank you, Dr. Ibrahim, for the good lecture and informative lecture. It was helpful. And apart from the theoretical part of it, which maybe needs for some revision and repeating, I want to ask about the spirometry, especially the practicality part of it. When the patient comes into the office and the patient has an asthma attack or an exacerbation, he doesn't have the ability to do a forced expiration. So will you wait until the patient has maybe the capacity to blow the spirometry, or you immediately give them and assess from there, and then when you give the bronchodilator after that, again you do the second one to compare? That's my number one question. Number two is the training. Like the Somalis ask, when you give the patient, he has never done that test before. So the patient you try to train. So how long do you wait to train? Like you give the first one, he doesn't know, and then you wait, and then you give second time to do the test, and then the third time you gave the test, and he's not giving the expected one. So that's another question I want to ask. Thank you so much.
Yeah, excellent questions. So number one, for asthma, normally what we do is what's called we do something similar than the spirometry. So we do what's called peak expiratory flow. So what it is, they have a small very device, and to see how much air they can get out fast. So and when you're seeing this patient in asthma, when they are normal, you ask them to do the big expiratory flow, so you know what their expected is. Okay, so when they are controlled, what their expected is. And then you give them this device. Actually, it's very, very tiny device. It's disposable, it's cheap. They blow, and then they can say, oh, I'm doing 80% or better than what I normally do. So you are okay. If they're doing between 50 and 80, then you know, okay, you are in the yellow zone. So sometimes they may have to increase their medications and take their PRN medications more frequently. And then, but if they are below the 50%, that we call the red zone, then at that point they have to seek medical help. So to answer your questions, when the person is in exacerbation in asthma, you do a just simple peak expiratory flow to see where they land. And that tells you how severe the obstruction is. Guys, you know, the patient is short of breath, they cannot talk full sentences, you listen to them, they're wheezing. So you don't really, you know they have asthma. So at that point, all you need to treat, but you want to know, say, how bad is it? Is this guy patient need to go to the hospital, or if he, if he is, not able to talk in sentences and things like, you have to give him a bronchodilator and then wait. If he improves significantly, then you might be able to send him. But for us to quantify a little bit, I think peak expiratory flow is really the easy way to do it. And then you can test this person if when they are not in exacerbation to see a baseline lung function to see where they land. So to answer your question, that's how we approach asthma. Just what's called peak expiratory flow. And people actually can test this at home if they have this very tiny device, and they know, so they know when to go to medical, seek help on. So that's one question. The second question was, I forgot. I'm sorry, I forgot the second question.
Okay, the second question was about how frequent, I think it was how frequent you do
yeah.
training.
Okay, excellent. Okay.
Yes.
So
the first one you failed it, the second one.
yeah. So when on this pulmonary fraction test, we have technicians and trained people who does this, and that person that you train and to do, normally we do 3, and they have to be acceptable. And there is a criteria for you to be acceptable. That's, for example, you have to take a full lung, and then you have to breathe out, and you have to be breathe out at least 6 seconds or something like. So there is an established criteria you have to meet, okay, and to be accepted. So you have to have at least 3 accepted ones, and then you take the best one of those, okay. So it takes a little bit of so you need to have a technician or somebody who does this, who is a people person, and say, hey, we need to breathe in and we need to breathe. And then you will see, even now when I go to the office, you will say, people scream, say, breathe. Take a deep breath, stop. So you have to have somebody who work with that, and you have to model it, and you have to say, hey, let's take a deep breath. And then breathe out, fast. So you have to have somebody who is really good with people. But if you show people, 1 or 2 people, say, this is how we have to do it, and this is how the test to be useful, I think most of the time it will work. Again, it will not work if the person is very short of breath. It's not probably the time that is the most useful if the person cannot breathe. But it will yeah, again, it takes some coaching. I agree with you, but you have to have, and sometimes we look at the test and we can say, okay, this person did not breathe, did not take long enough, so we don't use that test. So there is a criteria to say acceptable test, reproducible test. You have to have at least 3, and usually you take the best ones of those. Let's see if I can put the other test, the other lecture.
waa Dr. Hanfi, marka anesthesiology ayaan in yar idinka sheegayaa iyo xiriirka naga dhexeeya pulmonary function testiska Dr. Ibrahim oo kale. Marka aan noo yimaado qof u baahan qalliin weyn oo ama kansar hadduu lung kansar qabo oo sanbabka qayb dhan la goynayo, ama ay noo yimaadaan bukaan qalliin yaroo kale u baahan laakiin qaba xanuun COPD khatara, waxaanu la kaashanaa Dr. Ibrahim oo kale aan u dirnaa. marka Dr. Ibrahim waxay naga caawiyaan inay bukaankii test gareeyaan, ay eegaan pulmonary function testkoogu siduu yahay, iyo haddii la improve garayn karo oo marka pulmonary dilator la siiyo inuu noqon karo. marka xiriirkaasaa naga dhexeeya. marka Ibrahim hadduu wax yar ku dari karo waan.
Yeah, absolutely right, Dr. Hanabi. Well said. And that's why we use it sometimes for preoperative evaluation. So, for example, we use it using people for lung cancer. We say, okay, we need to take the whole lung out. Can this person live on one lung? Okay, so we do the pulmonary function test, or no, we say we cannot take the whole lung out. Can we take a low part? Okay, so then we say, okay, how much air is he getting in? How much is he getting out? And then sometimes we also do specialized tests to say, okay, where, especially if they have like the COPD, sometimes we do what's called lung reduction surgery or pull apart. So we say, okay, how much, can we close? So you can tell actually how much air is going to the right lung, how much going to the left lung, how much is going to the upper lobe, how much is going to the left lung. So this test is actually useful. We also say, like Dr. Hanafi said, if this person goes to the OR and put on a ventilator, are they going to come out of the ventilator? Are they more likely to develop pneumonia or prolonged mechanical ventilation, depending on how much pulmonary reserve that they have? So this actually is very, very useful to tell you, okay, this person has getting air in, getting air out, transmitting oxygen, his lung function is okay. So we tell them, go ahead, you do the surgery. We can tell them you can take this part out, you can make this part out. So if the patient cannot have surgery, they may have chemo instead of radiation or something like that. So preoperative evaluation is one of the more common things that we use for pulmonary function tests. All right.
Thank you very much. And please proceed to the second.
All right. So the second one, and it's maybe a little bit connected, and that's why I want to do the pulmonary function test, is maybe a little bit of update about the pathophysiology and treatment of a COPD. This is the usually normal image we see on a COPD, a cachectic man, that's old one. This is now more of the face of the COPD. Woman is becoming actually almost as common as man, maybe even more common. These pictures are from my textbook, pathophysiology textbook when I was a medical student.
sheekada yareeya iyo codka insha Allah.
So if you look at if you look at this as a 67-year-old man present with history of dyspnea, with progress of several years, worsening shortness of breath, it forced him to retire. He's a smoker. He have to go to the emergency room twice the last year. His physical examination showed diminished breath sounds, auscultation with prolonged expiratory phases. These are key things that you usually see on the stem, you know. And then look at the spirometry, and this is why now you are very familiar. The ratio is 43%, okay? And you know that is very, very, that's obstructed, was less than 70%, you know that. And you look at the FFU1 and it's 34%. So this is severe. It's not less than 30%, but it is between 30 and 50. So you know it's severe. So you know he's obstructed and he's very severely obstructed. Okay, all right. And you know he's a smoker. You have a diminished breath sounds, prolonged expiratory phase. You know all of these things. So you know what this case is. You know it's a and you look at his X-ray and you look at his full hyperinflated lung, flat diaphragms, okay? All right, see the diaphragm normally is supposed to be like that, dome shape, but see how now it's flat it is because it's full of air, that air that's not coming out because that he's not getting air out efficiently. Remember that, okay? All right. So he's more of the obstructive type instead of the other. So what's the diagnosis? And according to this parameter, this is obstructive disease. So you know it's most likely COPD. And what causes it, you know that again, it's most likely is smoking, and how severe it is, we know that it's very severe. And then we're going to talk about how to prevent it and how to manage it. Okay. All right. We'll talk about a little bit of definition. Again, percentage change. The COPD is really, really one of the diseases compared to all the other diseases is rising. It's really continue to rise. And it's rising because a couple of things. Number one, air pollution is becoming more. And we are still smoking heavily, especially in our countries. We are still smoking, and especially like India, like China, which most of the population located, they are continue to smoke in Indonesia, and air pollution is becoming more, and also people are becoming older, especially in the Western world. So again, remember I told you when the lung function peaks and then it gradually. So if we live long enough, we're all gonna develop COPD, okay? Because again, we are losing about 30 cc of lung volume, you know, every year, okay? So there's a finite life for the lung function. So what's COPD? COPD is a heterogeneous lung condition characterized by chronic respiratory symptoms. So you see people, they are dyspneic, they are short of breath, they cough, it's a chronic cough usually. They may have some sputum production. They have an exacerbation, they go up and down. Sometimes they are worse, they can hardly breathe. Sometimes they do okay. So it goes up and down, but they have a chronic cough, chronic symptoms. Unlike asthma, which sometimes is completely asymptomatic in between, okay? So COPD is due to abnormalities of the airway. So I want you to pay the key equations. It affects the airway. So it has a bronchitis, bronchiolitis. So the airway is the tubes. Remember, you have the trachea, you have the main bronchi, then you have a subsegment. Those are, and then smaller, okay? Bronchi, bronchioles. So that airway, that's the tubes. It affects the airway, but it also affects the parenchyma, the alveoli, the alveolar sac, where the air goes to. It destroys that. That's why you get the emphysema. So that's why it causes persistent, often progressive airflow obstruction. Okay. All right, we'll talk about that. So please attention. Air affects the airway. It's a persistent. It's caused airflow obstruction. There are multiple subtypes of COPD. You can have or obstruction, I should say obstruction. You can have asthma, you can have a COPD, you can have just, different airflow obstruction. You can have overlap. You can have somebody who have all of this. You can have somebody who have an asthma and COPD mixed together, okay? So it takes, but if you look at asthma and COPD, both of them are obstructive lung diseases, okay? All right? One of the things that, we can tell differently, usually asthma starts as a young age. COPD usually is an older age, usually because it's a disease that comes from irritant and damage and destruction of the lung that takes some time, okay? Although it can happen. So these are not absolutely 100%. We see young people who develop COPD early, and we'll talk about those sometimes. But in general, asthma people usually are younger, and asthma develops early. COPD, like the types of inflammation, usually, if you see in asthma, what they say inflammatory cells, usually you say eosinophils. COPD, mostly neutrophils and macrophages, okay? lymphocytes, usually asthma, think about, I said, younger age, think about the lower numbers, CD4, IL5, COPD, the older, the higher age, CD8, IL8, things like that. Again, asthma usually is from allergy, from dust, boorka iyo waxaas, yani ka dhalata, yani is allergy. Maybe 90% of it is like that. It's extrinsic, what we call it, atopic asthma, okay? Usually COPD, we don't see any allergies. Asthma is usually reversible. So sometimes they tell you, man, some days I'm good, you know, but then sometimes it just, I cannot breathe. So that's more classic type of asthma. COPD, the symptoms may vary, but usually they have some symptoms, especially when they have a moderate to severe COPD, they have some level of symptoms most of the time. All right, so just keep in that mind. Okay, when you see somebody who's short of breath, you're thinking about, is this asthma, is this COPD? You know, you can't just have a just general understanding in your mind to see which one is more likely. What are the risk factors? So there could have, usually cigarette smoking is the highest risk factor. You know, I think in our community, maybe also dust, chemicals, and also indoor and outdoor pollutions, particularly inaga dhuxusha iyo fire iyo dabka waliba halkan is very, very important. Remember what I said, when you are developing young lungs and young, okay, if you are exposed to toxins, especially like fire, cooking in a firewood, smoke, especially in anaga hablehen oo kale, that is really, really can affect their lungs and lung development and can stunt their growth. And then they don't have as much lung volume as they would have otherwise. So usually there are genes that affect maybe like alpha-1 antitrypsin deficiency or something like that. But infection, recurrent infections destroy the lung and damage the lung and can cause COPD. Socioeconomics, COPD, they used to call the poor man's disease because all of these things that damage the lung it is common in low socioeconomic status. But again, also aging population is contributing to that. So because of all these things, COPD is increasing. Okay. So this is actually hot off the press, and I think this may have not been completely adapted yet, but it is 2025 goal guidelines included, and there's different types of COPD. The generic COPD, so we call COPD-G, that's basically the ones who I was talking about, alpha-1 antitrypsin deficiency. There are people who are genetically predisposed to destruction of the lung. Okay, and this they develop early usually, and usually they have a family member who have died from the disease or something like that. COPD due to development. This is what I was talking about, early life events like the people who are exposed to biofires early and toxins early, and they did not develop, or the people who are premature babies. Again, environmental COPD, like cigarette smoking, for example, biomass. COPD due to infection. That's what I was talking about, especially they were talking about tuberculosis. We have a lot of people specialize in tuberculosis. And I just want to tell you a story about, I am from Borao. I grew up in Borao. I graduated from Ahmed Ali, yes. But TB hospital, this is one of the things that get me interested in medicine, because I thought they do magic there. I used to see people walk in as a skeleton, you know what I mean? And then they stay in that TB ward for like weeks. And then they come back as a normal people, gain weight, and they look. I said, man, what are they doing there? Are they magic there? I said, black magic. So I was impressed with the power of medicine, really how it can almost bring people from the dead, you know? Wow, it was really amazing. So I really, my hats off to you, you guys doing that. You're really inspired. mask, but you bring people to life, you really make a difference. So really, congratulations to you. And this is one thing I love about medicine. So that chronic infection is a recurrent infection, bronchitis, TB, pneumonia. They destroy the lung and then can develop COPD. Again, you can have a COPD and asthma. You can have a COPD of unknown. So we are trying to tease it out and just say COPD is a big bucket, okay? And all of them lead to destruction of the lung, but they might come from a different causes. To diagnose COPD, you have to suspect there's supposed to be a reason. Somebody has symptoms, they are smoke, there's a risk factor, there's exposure, there's an indoor pollution, there is a occupation, there's tobacco, and then there's a symptoms. So they are short of breath, they are coughing, they are having a sputum production, they have something like that, they have to complain. So when you have these two, then you can test and you can do the spirometry, okay? And the first thing you do that is do the spirometry, okay? And it is required to make a diagnosis. If you do not have this, you cannot really say, I know you have a COPD. You can suspect it, okay? Like we clinically suspecting it, but you do that spirometry. And we used to say you do a both bronchodilators, okay? So what that means is that, like the question they were asking me earlier. So what that means is the patient comes in, short of breath, you give them a bronchodilator, and then you wait for a while, maybe 15 minutes or 30 minutes, depending what you gave, either albuterol or atravan or ipratropium or what you gave. So then you do the test. But that may be changing and making it easier for you guys, and I will go over with you. But you have a risk factors, you have the symptoms, and then you do the spirometry. This is why spirometry is really, really important. And then you confirm. If you don't have obstruction, you don't have COPD. I want to make sure that that comes across. All right. So when you have an airflow obstruction, then you look at the severity of the airflow obstruction by looking at the FFE1. You look at the current level of symptoms, how bad his symptoms of the patients are, what can they do, and we'll talk about that. We look at if they have a frequent exacerbations or how bad, and again, there's some symptoms at baseline, but those symptoms can worsen and then can come down, okay? And the exacerbation is actually one of the worst ones because every time you exacerbate it, you destroy more lung and you never get back to where you were. So we try to minimize exacerbation. That's one of the key things in treating a COPD, okay? And there are some more comorbidities that's present if they have usually like the thing that affects the lung, it's also affect the rest of the body. If you smoke, and then you have a cardiovascular disease. If you are exposed to toxins, then toxins also, destroy other organs. So it's not only one thing. So how do you assess the COPD? Usually you assess the COPD by symptoms. So there's a multiple way to assess. And this SAHA right now has been really, really standardized. Okay, so you can use one of these two tests. To me, one of the most easiest tests to do is the last one. Modified British Medical Research Council questionnaire, but I'll go over with you with both. And this is like a New York heart classification. If you are familiar with New York heart classification, it's really, really similar. Just, one statement that you can get an idea. If the person tells you, I am too breathless, I cannot even do anything. When I'm trying to put my shirt on and get out of bed, I'm short of breath. You know that he's on level 4. If he says, no, I can walk only 100 meters and few minutes, and then I'm short of breath, you are level 3, okay? If, he said, yeah, I can walk for a while, but, I'm still not able to keep up with the people like my age, then, it's a level 2. And so you can get an idea where it is. It's really, really good to see where the people are. This is the other one, is a COPD assessment test. And all of these are just, something that people can fill out when they are sitting and waiting for you to be seen. And you can just say, I never cough or I cough all the time. So they can grade it from 0 to 5. And they have and they can say, I have a lot of energy and it's here, or I don't have any energy at all. So you can put here 5. So the maximum you can get is 40. And if they are more than 10, then that means they are symptomatic and they're having symptoms. And the higher the number, the worse the symptoms they have. Okay. But again, I like this one better because it's easier, it's simple, but either one is fine. And we do actually this one in our clinic. Everybody fills out one of these before we see them, and we look at their score. And again, this is what it is. That if you have less than 10, then they are okay, the symptom-wise. If they are between, then the higher the number, the more symptoms they have. All right, so this is the same one I talked to you before. Again, then you quantify the airflow limitation. Okay, I wanted to separate two things. Spirometry quantify airflow obstruction, not COPD, only airflow. There's a airflow obstruction is one thing, and COPD severity is same thing. So how bad your FFU1 is, which is like they have some people who are very, very low FFU1, but their symptoms are not that bad. They don't go to the hospital. There are some people FFU1 is here, and you think they should be okay, but they are so short of breath. So that's why the two are not equal. I just want to make sure that in the past that has been confused. A lot of my students mix the two up. Airflow limitation is a component of a COPD assessment, okay? But that becoming actually less and less, okay? So they not the two, they're equal, okay? So we take when we are quantifying a COPD, we take the symptoms, we take the history of exacerbation, which is actually becoming more important, and we quantify the severity of COPD. But FFU1 and spirometry only quantify the airflow limitations. Okay, so also in the past, it used to be we do a bronchodilator, but that's also changing here a little bit. So, and actually this is what and this is really hot off the press on 2025. And it's making it easier to measure obstruction. So what they say now, you can either do pre or post bronchodilate. Okay, so when the patient walks in, you can just measure and do his spirometry. When you do the spirometry, if the ratio is normal, you don't have COPD, and you're done. You don't have to do post bronchodilation. You don't have to do anything else. Again, the patient walks in, you suspect COPD, he has a chronic cough, he is a smoker, and you do the spirometry, and you do the ratio, and the ratio is normal, you're done. You don't have to do anything. You don't have to do bronchodilation. You don't have to do anything, and it's done. Okay. If the ratio is abnormal, then you say, okay, does the person really have a COPD or not? So you do the bronchodilation, okay? Because you don't want to, this could be asthma, all we know, okay? So you do the bronchodilation, and if the bronchodilation, the obstruction resolves, it's more likely more of an asthma or something like that, or maybe even early COPD, something like that. You don't. But if this is, the ratio is abnormal, then now you have COPD. Okay, so this is actually something is very, very new and changing. So I just want to include that here. So, and actually it makes easier actually to do evaluation. So again, you don't have to do bronchodilations anymore. Unless it's abnormal, then you have to do it confirm. So this is how we assess the COPD. And we put all of it together. You have somebody who have symptoms, We did the spirometry. Spirometry show airflow obstruction. Because again, if it is not airflow obstruction, then we say we don't have COPD. Okay. So then you say, okay, how we grade the airflow obstruction to see how it is. And goal, they use 1 to 4. And you can say 4 is very severe. Goal 3 is severe. Goal 2 is equal to a moderate, and goal 1 is mild. Okay, so whichever, either you use 1 to 4 or use mild, moderate, severe, very severe. Doesn't matter. So what you say here is, you look at the person, how much of a symptoms they have by using those things I just showed you earlier. You can either use the CAT score or MMRC, whichever you use. I like the MMRC because it's simple, okay? But so if MRC is more than 2, or if it's CAT.
Dr. Ibrahim, to interrupt you, you have around 10 minutes to conclude.
Okay, all right, thank you. All right, so I will appreciate it. Thanks for that one. So you look at this and you say, okay, if he doesn't have symptoms is this, meaning CAT's less than 10, MMRC is 102, then he is in this group. If he has some symptoms, he is in this group, okay? And then you look at exacerbation. Did he have any exacerbation? If he had less than 1 exacerbation, or at least 1 hospitalization, he is in here. So you say, okay, if the person have a lot of symptoms and he has an exacerbation, he's in class E. If he has symptoms, but he doesn't have much exacerbation, then in class B. If he doesn't have much symptoms and he has an exacerbation, it's class A. So class A, class B, class E is quantifying a COPD. How about COPD? If somebody having a lot of symptoms and they're having a lot of exacerbation, they are E, that means they have a severe COPD. All right, so, and that determines how we treat them. Okay, all right, so I'll go to the treatment and I'll try to go quickly. Oh, before the treatment, again, COPD is caused by enticing agents like cigarettes, occupational, all these things we talk about. That causes and triggers innate immunity like macrophages, neutrophils. They try to get rid of these toxins. You know, that's what they were designed to be, okay? But when that toxins keep coming, they are overwhelmed, okay? And they release inflammatory proteases, and that inflammation causes a damage and releases free radicals, you know, oxygen radicals. Like, see, this one say, oh no, man, it's destroying everything. And that destroys the epithelial, endothelial, okay? That destruction causes emphysema and loss of a lung function, okay? So again, this is more of a cartoon form, okay? All these toxins and cigarette from the cigarette, the macrophages, they try to mediate and try to get rid of it, but eventually that becomes overwhelming, and that eventually leads to destruction of the alveoli. And the lung try to report it, and they become fibrotic. Okay, so this is really, really very important. I want you to look at it, and especially I want the residents and young students to look at it. Normally, this is how the lung is. That you have an alveoli, and then you have a connective tissue, and they keep the lung, the alveoli, open, close, in a regular. They are open and they are closed. Okay, there is organized fashion. Let the air in, let the air out. Let the air in, let the air out. And that's very inspiration, let the air in, expiration, let the air out. Okay. So this is the lungs, alveoli here down at the bottom. All these little bubbles, and you have millions of those alveoli that closing and opening. Just imagine, just sitting there, and you have these little millions inside you opening, and you don't even know. What amazing creation that is. But when you have the COPD here, and this destroy these connections, and all these little alveoli can no longer open or close in organized form, and they cannot even get rid of that air, so they don't contract very well. Okay, so they call it premature closure, and that's why they cannot get the air out. That's why they develop hyperinflation. If you look at this small alveoli in a big electron microscope, you can actually see this little tiny connection and how that really regulates. It's 100 times thinner than a hair. You cannot see it. But when you look at that, you can see it. But when it's destroyed, it becomes like this mess. Okay? This is what smoking does to the lung. This is what toxins does to the lung. That's why the lung doesn't function. Okay? So I'll go through this again. The goal of the treatment is to eliminate and reduce the symptoms, reduce the frequency and the severity of exacerbation, stop or reduce the progression of the disease, improve quality of life and health, and decrease mortality. So again, COPD, I said the lung function gradually normally declines, but if you smoke or you have COPD, it goes like this. If you stop smoking, it gets better. Even if you stop smoking late, it gets better. Smoking cessation has the greatest influence of the natural history of COPD. That means that's the most important thing that you can do. Pharmacotherapy, like nicotine replacement, it really improves smoking cessation, and we have to supposed to give everyone who smokes. All COPD patients benefit from regular physical activity. Again, don't get tired of telling the people to stop smoking, because that's one of the best things that you can do as a physician. As a physician, we don't want to just take care of people who really, really cannot breathe. We want to keep the people healthy. And if we can keep people healthy in our society healthy, our physicians, maybe we should get paid keeping the people healthy instead of, helping the sick ones. Maybe we do both. But again, the more we do the first and try to keep our people healthy, I think that we will do better. I will skip this, but this is the questions you ask them. If they smoke, you advise them to stop. You assess if they are ready to stop. And then you assist by giving him a medication is to quit. And then you arrange them a date that you to quit. It's really, really important. Again, reduce the symptoms, relieve the symptoms, improve exercise, improve health status, prevent exacerbation, and prevent disease production, and reduce mortality. So I will skip this, you guys, this is a differential diagnosis. We have halal vaccinations. Make sure that we do all the vaccinations now, including COVID-19, influenza, pneumonia. These prevent infections and prevent the exacerbation is mostly triggered by infections. So if you eliminate and minimize infection, especially in our part of the world, I think that you can preserve lung functions. Again, how do you treat COPD? Mostly COPD, you treat it with bronchodilators, mostly long-acting bronchodilators, mostly muscarinic bronchodilators. So long-acting muscarinic agonists, LAMAs. So these are the most stable treatments for COPD. And this is different than asthma. I'll talk about it in a minute. So the best treatment for COPD is long-acting antimuscarinic and long-acting beta agonist. And this, so if it's a mild disease, then you may just have to do a inhaler as needed. But if they are more severe, they have to take scheduled medications. And then you, okay. I put this list on you so you can review on your own. Can have all the medications for long-acting. And now they can put all of this together. They can put the long-acting beta agonist and long-acting muscarinic agonist together to take it together. One of the most frustrating part of these inhalers are very expensive and they may not be available. And this is really, really one of our struggle, how to make this available consider initiating inhaled steroids. Inhaled steroids, really, especially those of you who are taking the boards, are not recommended for COPD. Only if you test them, if they are not responding to everything else, and they also have a high level of eosinophils. If they have maybe even an asthma, or if they have frequent exacerbations, then you can use inhaled steroids, COPD. All right. I think this is to skip. Again, and if you look at that COPD, I show you if they are class E, then you have to combine the medication. You have to have both LABA and LAMA, long-acting beta agonist and long-acting muscarinic agonist. If they are in this group, you just maybe just a bronchodilators as needed or things like that. If they are here, you can still use LABA and LAMA. Up here, you may have to add inhaled steroids. You may have to add other things. What we call here, we throw the sink at them. We do everything we can, try to make them, because these people are very symptomatic and they are going to the hospital and they have frequent exacerbations and things like that. So we try to stop that. Non-pharmacological, again, smoking cessations, rehabilitation, that's the best thing to do. I was trying to see if I can get oxygen. Oxygen, this is very difficult and it's very expensive even for us, but these are criteria. If they are hypoxic, and that means their lungs destroyed, then you have to put them on oxygen. And those of you who taking the boards, this is one of the way to reduce mortality. So I'm supposed to talk about a little bit of asthma, but again, I don't have time, but just a reversible obstruction. FFE1 is reversible. Mostly is extrinsic or atopic. Like I said, it's mostly something triggered by something. Non-pharmacological treatment is usually to avoid and minimize the triggers. Treatment is completely different than in COPD. It's usually inhaled steroids. And you can use it then beta agonist, either short-acting or long-acting, if the inhaled steroids doesn't help. We really never use a long-acting muscarinic agonist for COPD or for asthma. Okay, so COPD, the first line of treatment, long-acting muscarinic agonist and beta agonist. Inhaled asthma, inhaled steroids. That is the difference. Okay, so take-home message. Definition and diagnosis of, we'll talk about COPD. We talk about how to quantify COPD and how is that different than airflow obstruction. We talk about non-pharmacological, especially trying to stop smoking and eliminate the risk factors. And then the treatment is LAMA and LABA maintained. Tobacco cessation has the biggest impact. So don't get tired of telling people to stop smoking. With that, I thank you.
aad buu mahadsan yahay Dr. Ibrahim, Sultan Cabdullaahi, Sultan cali. wax su'aala miyaynu weydiinaynaa waqtigeena runtii aad buu yaryahay hal lagjar baa inoo hadhay oo khafiifa oon badnayn. wax su'aala ma jiraan? Any question? mahadsanid Dr. Ibrahim, aad iyo aad baanu kugu mahad celinaa, jazaaka allah khayr. waanaanu insha allahu tacaala kula soo xidhiidhi doonaa haddii ay beydmo si aanu cilmiga aanu insha allahu tacaala wuxuun kaaga weelayno haddii ay beydmo. waxaynu u gudbi doonaa iminka lecturekii ugu dambeeyey. Dr. Cadnaan diyaar miyuu yahay? Cadnaan Cabdallah Hirad.
السلام عليكم.
وعليكم السلام ورحمة الله وبركاته. iminka insha allahu Cadnaan yare ayaa diyaar inoo ah insha allahu tacaala. kelmaddan yare iyo bidaartay gadhkan weyn malaa way sukiin qaban weyday laakiin
beri baan kaa yara aniga oo laakiin ka u malayn maayo inaan kaa yarahay.
كان اسكو جلاس بانو هان جرني مركا ان شاء الله تعالى كسو دواada عدنا waa PhD وانا researcher marka iminkana insha Allah تعالى researchka ayuu inaga horan doonaa insha Allah wax ku saabsan soo dhawow
shaashadayda si fiican uma aragtaan
si fiican baanu aragnaa
Neo topic gun horta I haven't given it to Somali speaking populations before. So this will be my first trial and we'll see how it works out. But I have one goal, and that is just to make you understand how evidence is produced in modern medicine, right? When you say, I saw Dr. Ibrahim was showing one of his lectures, he was showing, evidence level B, or he was saying there were recommendations by, via consensus or such thing. How do we know that is the appropriate evidence to use in treating patients, right? And what are the how did we get to that point, and what are the ethics that are involved in producing that evidence? And then I'll talk about a specific case where basically the development of the mRNA vaccines that you guys probably took, and many of us here in the US took, and how that can be used as an example of that evidence-based medicine and the generation of that medicine and the ethics that's involved and such. So, and then if we have any time left, I can talk about my research, which is pretty complicated and esoteric, but I think you might guys enjoy it. So when we say evidence-based medicine, the name itself implies there was a time when medicine was practiced that people didn't actually use evidence, right? Or didn't need evidence. So what did they use in place of evidence? That doesn't mean they didn't have evidence, but it was just based on, the Somali way of doing things, right? How many of you are Malay? And if someone, has diabetes, they can drink camel urine, and that will make them feel better, right? Back in the day, not long ago, maybe about 200 or so years ago in the West, that was how it worked. A doctor practiced, they found something that worked for them, and then they did whatever they wanted to do. And then training was based on apprenticeship. So someone would find, someone will say, I want to train under you as a doctor. And then whoever you trained will know how to use this one item or this particular medicine for this disease. So one can say medicine before this era of evidence-based medicine was based on clinical expertise or physician judgment. Unfortunately, that wasn't working for a lot of patients. And so another element had to be developed where best practices or best research evidence has to be gathered, and systematic studies and data have to be shown for something to be considered appropriate to use for patient treatment. On the other side of things, patient values are important now, meaning you can't, there has to be a cultural fit and a fit between the patient and what the doctor is doing, and there's a shared decision making. So, if you see someone who has a broken leg, for example, and they don't want to get treated in the US and in the West, you can't just take them from the street and put them in the hospital. That is unethical. So the patient's required needs and values have to meet the best evidence. And from there, we have the makings of modern evidence. I'm not going to read to you this current definition of what evidence-based medicine means, but it basically means, it says, we need the best evidence based on data and science. We have to take into account patient goals and values, and there has to be shared decision-making. So if someone is, 80 years old and says, look, I do not want chemotherapy for my cancer, and I would rather, die, you can't say, no, you have to get treated, right? If someone says, look, if, I'm intubated and I want to, I don't want to be intubated. I just want to, go. You can't really force them to be intubated, right? Now, I just wanted to show you that I took a screenshot of what Dr. Ibrahim was presenting because evidence, right? He had to show you this, right? He can't, 100 years ago, he could just say, look, I told you, LAPA is the way to go for this subject, this patient, and it's what I say, and that's all that works. So this era, basically, why was the old era not working? There was over-reliance on expert opinion and tradition, meaning I used to do things like this. It worked for me, therefore it must work for you. There is variability and lack of standardization in care, meaning basically one patient was treated with, I can hear other people's voices. Dad kalaan maqlaya codkooda. Ismute gareeya. There was variability and lack of standardization in care, meaning, one person with COPD will be treated with drug X, and then another person will be treated with drug Y. The reason for the decision was never given, and that wasn't really working for patients, and we couldn't figure out. Now, there was also lack of transparency in decision-making, meaning why something was done was never clear. And it was ineffective or harmful practices basically were, perpetuated for a long time. So, for example, there was a certain antiarrhythmic drug that was being used in the 1980s that increased mortality. And there was no way to stop that kind of treatment because there was no, there wasn't a consensus and a process for getting new drugs into the market or into patient care and taking harmful things out of the system. Here I just show you the timelines of that we have for generation of evidence especially in the West, right? The main one to focus on here is this scurvy trial, right? Scurvy is vitamin C deficiency. You guys know of this as medical students, I'm pretty sure, leading to bleeding gums and such. And in 1747, a group of British sailors were basically suffering from this. And the captain at that point decided he's going to try a few different things. One group, he gave them oranges, the other group vinegar, the other group some other stuff. And what he found out was that the group that he gave the oranges to basically got better. And that's how we know. From that day on, we know that scurvy is a disease caused by deficiency of vitamin C, right? Now, 1946, though, is when we conducted the first, what they call RCT, and control trials, randomized control trials, and that's the highest standard of evidence, and I'll explain that a little more later on. But there were also ethical codes that had to be developed between 1947 and 1979, and I will explain to you why that is. And then finally, we have a codified process of evidence-based medicine. What does that mean? And that's basically what I was kind of describing. So I kind of skipped this story, and now I'm going back to it to explain to you. Now, we'll start with the ethical codes, right? The ethical codes. So when you see ethical codes or the right way of doing things, they usually come out of failures that happened before. One of the major failures was a Tuskegee syphilis study, for example. Hundreds of black men American black men were misled and denied treatment for decades. We knew at that point, we knew penicillin treated syphilis. They were not treated, and they developed tertiary syphilis, which you guys all know is a very severe disease. There was a sedative that was given to pregnant women without testing, And that led to greater than tens of thousands of babies being born with defects. There was another trial that even after we knew these codes and the right ethics, there were some failures where the first monoclonal antibody was tested on 6 people directly, and that caused a cytokine storm, and those people died immediately, right? So those failures are what motivate the ethical principles and guidelines we have today for how to conduct the appropriate research. Now, the core principles are respectful persons, like the person's autonomy, beneficence, that you actually, when you are doing the research, it should be something that will be of benefit to humanity or them, and definitely do not do harm, and be just, meaning don't treat the guy from your tribe differently than the guy from tribe B, right? And just in general, speaking of these codes, the first one of these was 1947 by the Nuremberg Code, and it enshrined voluntary consent, scientific, meaning basically the person participating in the research has to consent to the research. There has to be scientific merit to what is happening, meaning you can't just do fun experiments on people. There has to be evidence leading to what's happening. That then leads to the research you're planning to do, and you have to avoid unnecessary suffering. This particular code was codified specifically because Nazi doctors in the 1940s, in the 1930s, were practicing on the people who were living, who they captured and were in the concentration camps. And this was one of the first reactions of how should doctors behave towards people that they're treating or in research. That was further codified in a declaration called the Declaration of Helsinki, which also at that point addressed a very important point, which was there wasn't an independent review, right? So let's say you're doing research with subjects, you decided what was appropriate. Although you followed these guidelines here, voluntary consent, scientific merit, and avoid unnecessary suffering, still there was no independent group making sure that you're actually following the appropriate ethical code. So here, independent review was added. And then later on in the 1970s, when the Tuskegee trials problems came out, this was in the US passed in law, it became law, right? It wasn't anymore a recommendation, it was law. If you violated it, you could go to prison, especially intentionally. Now, in today's practice, anytime you're trying to do research, there are very specific things you need to have. You have to have informed consent, meaning the patient, the subject you're studying has to know everything, right? You have to explain the purpose of the study, the procedures, the risk and benefits of your study. The participation is voluntary and ongoing, meaning at any given time, the participant can say, look, I want you. So I conduct MRI studies on subjects. And in this scanner, it costs us a lot of money. If the subject says, look, I want to stop the study right now, you have to stop right then and there and get them out of the scanner and then send them home, right? And you have to be participant welfare. You have to make sure you monitor their safety and adverse events, like if if there's a drug therapy involved, and you have to take extra care when it comes to vulnerable groups, right? Especially children under 18. They can be influenced by their parents, and so you have to find ways to make sure that they really want to participate in this. You can definitely not just study prisoners, right? Prisoners are captives, and so that's a big problem. And then those who are incapacitated, right? If someone is not able to consent, meaning they don't have all of their faculties to consent to what's happening, then there are also very, very specific and special considerations one must take. Now, I just wanted to bring that back. The Tuskegee syphilis study, for example, is what led to the IRB protocols, right? This disaster led to what we have today, the phase trials. You have to do dose testing. And this monoclonal antibody problem and crisis also changed the way we do trials further. So, for example, in this trial, they gave all the 6 subjects the monoclonal at the same time, and they started with the highest dose possible. Now you can't do that. You have to start with very small number of subjects. You have to do small amounts, and then you can decide. And then from there, you have to you can't just do everything all at once, right? So all of these disasters that happen are supposed to provide feedback into our guidelines and the way we treat patients and do research. Now we still have huge ethical failures, right? I don't know if you guys heard about the opioid crisis in the US. There's a company called Purdue Pharma that basically produces OxyContin, and they promoted it as low addiction drug, right? Their representatives, they had marketing agents, and those marketing agents misrepresented the evidence. They basically did misbranding of the drug, and they had knowledge internally, right? They had knowledge that the drug was very addictive, and that led to huge deaths, right? Opioid addiction overdose deaths skyrocket. Around 2016, 115 people were dying from overdoses, and since then there had been legal settlements, and there have been a lot of issues. Now, this is really important for all of you guys, right? When we have evidence that something is harmful, we have to report it. If we shouldn't hide it from either our colleagues or from our patients. And we have to take every step possible to make sure that we are honest. And, for many of you I'm sure are Muslims, right? Or all of you are Muslims, depending on if they're, and, this is very important because Islamically, that's also what's required of us, right? Now we're going to get into the idea of evidence, right? So how do you know drug A, let's say, ibuprofen treats inflammation, right? Or is an anti-inflammatory drug. How do we know COVID causes, or the SARS-CoV-2 virus causes COVID, right? What I want the medical students to always think is, when they think about the medicine they're learning about, is how do we know that this is the right thing? I think starting with questions is a good way to train yourself as a physician. And down the line, we need to, of course, develop physician scientists in places like Somaliland. So asking the question, don't just take things for what they are, ask the question, right? So just a brief history. There's what's called the Henle hypothesis, right? 1840 or so, basically postulated that specific living agents actually cause specific diseases, right? We take that for granted today. We think this is normal, but at that point, they didn't actually know, right? They had all sorts of crazy theories. And then Koch developed important postulates, right? He proved anthrax, tuberculosis, cholera, and these diseases were caused by certain agents. And that standardization of pure culture, he developed basically how do you grow these things in the lab, and how do you basically give it to animals to see what disease it causes, how do you stain, and basically the methods that you can use to test this hypothesis, right? So this is called the hypothesis. This is the method you use to test hypotheses, right? So when you have a hypothesis, it's simple. To answer the question, you have to develop whole bunch of methods. You have to, create the protocols that are appropriate. You have to standardize things. And so he was one of the first to develop this, right? And in around 1884 and 1890, he developed what is called the Cox, the formal postulates, Cox postulates, which says organisms present in all cases. Basically, when there's an association between a disease and a bug, some sort of a bacteria, for example, organism is present in all cases and absent or far less frequent, low load in healthy hosts, right? Isolation, organisms isolated and grown in pure culture, right? We can do that. Causation, if you take what you isolated from the sick animal and you put it in a host that's susceptible, then that will cause the disease, right? So let's say Dr. Ibrahim and I are special species, right? We are very susceptible to bacteria called Americanitis, okay? I'm making up something. It's called Americanitis. Let's say I have Americanitis. Now we isolate this bug. If Dr. Ibrahim and I are from the same species, then Americanitis, when it's injected in Dr. Ibrahim, it has to cause the same disease process, right? So this is what this K3 postulate is saying. And then when you go into Dr. Ibrahim and you isolate the bug, the same bug has to be also found. So these are called the Cox postulates, right? Now you could already see a problem where it's like, well, that's one kind of evidence. You have to find one agent, one disease process. Is this possible to actually use? There are many other things, especially that cause disease, right? Many diseases are called multifactorial, right? It's not one thing that causes them. There are many different things that cause them. So by the mid-20th century, clinicians knew about chronic diseases, multifactorial diseases like cancer, heart disease, occupational environmental hazards, especially these last two, because these countries were industrializing very fast, and those Cox-style postulates wouldn't work, right? You can't give people cigarettes. You can't, ethically, it's not possible, right? So they had basically a scenario where if event B, for example, is associated with the environmental feature A, let's say some respiratory illness is associated with dust in the environment. In what circumstances can we say this is associated? So people who have, let's say, asthma, for example, when they're exposed to dust, they have asthma exacerbation, right? That's association. You could see that in your clinic and say, I have a hunch, maybe that's a problem. But how do you go from that association to say a verdict of causation, where you say this disease, dust, can leads to asthma or asthma exacerbation in most people, right? That is really a tall sort of evidence. It's not the same thing that we were testing here, right? You can't. And so for that, Dr. Bradford Hill developed what's called the Hill's criteria, and I'm not going to read this because I think I'm running out of time. I wanna go fast, but these are 9 postulates. So I want the medical students to learn 2 things: Cox postulates, okay, remember that and read more on that, and Hill's criteria for how, when the disease is multifactorial, you say the association can be thought of as causation, meaning this thing is causing this. A causes B when it's not a single agent to single disease process, right? And so there are 9 postulates. I'm not going to read this to you. I'm going to just show you, though, how the 2 compare, right? In Cox postulates, you're asking what causes what's the disease agent, right? You're looking for one bacteria, one virus, etc. In Hill's criteria, you're looking for association that can be causal, right? Like, you're taking an environmental thing, like the dust we talked about, right? That smoking causes lung cancer, right? Now we know that. But how do we know that? This is kind of a Hill's kind of study, right? That's why Dr. Ibrahim was telling you COPD, stay away from smoking, right? That's how we know this kind of thing. It's a Hill's kind of criteria study. The evidence unit, the thing you're studying, right? You're not studying a lesion or a tissue, a host level, single animal, single person. You're studying patterns in that across the population, right? So if, for example, the population of Bur'o has red teeth, right? We know what causes that issue, right? We're not going to do single studies because these are human. We're not going to, but we know the hard water is what causes it, right? But you can actually conduct a real study and figure out how those two things are related. But this is a population level pattern study. It's not a single host, single animal, single host level study. The proof, what kind of proof you need? For Cox, we talked about association, isolation, reproduction, and re-isolation. Here, in Hill's criteria, you need temporality, meaning the thing you're saying is associated with asthma has to precede, has to be before the thing, right? So, for example, smoking has to happen before you have lung cancer. If a person is born with lung cancer and then they start smoking, it's a weird thing. So temporality, this particular item is important at the population level. And then there's dosing and all of these other items that we can talk about, another time, because I don't think I have a lot of time to continue here. And then, okay, let's move to this now. There's hierarchy of evidence, right? The levels of evidence. So Dr. Ibrahim was saying evidence level B. That will be probably based on a consensus. It's not going to be based, maybe, there might be some clinical trials, but sometimes it's based on a consensus. The highest level of study of evidence is based on multiple rigorous studies. So let's say, I'm here at the University of Rochester. So let's say Ibrahim is in, somewhere in Tennessee, maybe Vanderbilt, one of these universities. And let's say at the center, we run two different studies, both of us studying lung cancer among smokers, right? If I find evidence and he finds the same evidence, now we can do systematic review or meta-analysis of those two findings. And that can say, look, the evidence is even stronger. Now, if I ran RCT, which is called a randomized clinical trial, which is a gold standard, this is the second level. You could run it at one study, at one site. And what's randomization, right? So you are not selecting people. You are basically saying, let's say one way to randomize is to say anyone coming into the Bur'o hospital let's say we have a new drug that we are giving to patients with hypertension, and we think it works for the people living in Bur'o, right? One group will receive the old medication that was being given to them. Let's say maybe they take thiazide or some diuretic. This new drug is, let's say, it's better. We think, we have a hypothesis, better. It worked in animals. Now you have to make sure the process is random, meaning, person one walks in, randomly you assign them to either the new drug or the old drug randomly, right? So there are many ways to generate a random number. Computerized randomization is what we use these days, right? And then there are other lower levels of evidence. They are called observational, like cohort and case control studies. And then case reports. So let's say you see something very interesting, right? In the clinic, it's one person, you've never seen it before. You can report that but that case report cannot be used as real evidence later on for treating other patients, right? And then there's expert opinion. It's important, it's useful. Maybe your patient population has a specific characteristic, the way the drug works for you, but that is usually prone to bias, and we've seen that from many years of studying, expert opinions, that there's huge levels of bias. So, we have an idea of what the levels of evidence are, right? So these are the levels of evidence when it comes to the population, when it comes to the drugs we give to people for many different disease processes. But how in the US, especially, and I think now everyone is following a similar process, what's the process that leads to someone having a hypothesis that drug A works for disease B, and then saying, let's go use that drug for drug B? You can't just have that hypothesis, right? There have to be a lot of tests. There's, first of all, a lot of discovery and clinical stuff, phase 1 and 2, 3, and then approval at phase 4 here in the US. Now, interestingly enough, there's a lot of research, billions of dollars of research, that biomedical research. Actually, you could say, about 100 to $200 billion of research happening across the US between private and government-funded research. Yet only 1 in 5,000 candidates become an approved medicine, meaning 1 in 5,000. That's a very low number, right? Basically dies here or leads to some discovery, but they never make it to the clinic, right? At the end here, I didn't put it down, is the clinic. Here is the lab. Here is the clinic. Now, phase 1 and 2, you test the safety of, let's say, the drug has been shown in animals, that it works. Then now you're trying to start the clinical trials process. You have to test the safety, right? If this thing is going to kill the person, then there's no point giving it to them in the first place, right? So what's the safety profile of this in humans? What's the amount, the dose you need? And then phase 3 is large trials that provide definitive evidence, and usually this is randomized. This is completely randomized, and usually it's blinded, meaning both the person providing the drug to the research subject and the patient do not know they're taking the drug, in most cases, right? So these are called placebo, double-blinded control trial, randomized control, and then there's the randomization we talked about. Phase 4 is post-marketing. So let's say even at phase 3, you have proven that drug B really works for, let's say, Alzheimer's disease, something we don't have a drug for. You still have to do surveillance and continually monitor, once you have it in a larger population, how this drug behaves, right? One other important concept to remember is the sample size. It's, statistics, right? The number of people you test gives us an idea, an approximation of the overall population, right? And so the sample size, so you can't do it on 2 people, you can't do it on 4 people, you can't, right? You have to do it on many, many, many people, and these are usually in the hundreds. There's something called power analysis you have to do, and then you proceed with your clinical trials. So just to talk about this whole process, is something that we all know of that went through this whole process. I want to talk about the mRNA vaccines. We discovered the messenger RNA in 1961, right? That there's some short-lived agent or molecule entity that takes the instructions from a DNA and then becomes a protein, right? That's what we learned. This is a long time ago, 1960. But you can see already that many people will say, look, if we can find this agent, we can get agents that are made in the lab and injected, let's say, into some animals and create vaccines, right? So a lot of people thought about this early on, even in 1980s or 1960s, 70s, and 80s, but they couldn't do it. The first translation happened in 1990 when mRNA was injected into a mouse muscle and it produced a protein. Now, you basically had an external mRNA and you produced a protein in an animal, and that was really an exciting finding, right? But there was one big problem. This thing, first of all, if you took the mRNA and you injected it into an animal, the animal had an immunoreactivity, reactogenicity. They died right away. They just wouldn't survive. And there's another problem. mRNAs are very, very unstable, meaning when you injected it, it didn't actually survive for too long. It basically, it had a very short half-life, what they call, right? So that basically made its use in, let's say, vaccines or any other therapeutic environment impossible. This group, Carrico and Wiseman, these two won the Nobel Prize in 2022 or 2023 for this particular finding. They realized what caused the problem with the reactogenicity, meaning that the immune reaction, and it was a specific nucleoside, uridine, that was causing this immune reaction. And they said they substituted it for something called pseudouridine, and the immunoreactivity basically died down. They also did something else. These mRNAs were usually not fully purified, so they took out other agents that caused the immune reaction, right? And then the stability, the half-life problem was basically improved by changing this thing has something called a cap. A group basically improved that 5' capping, and that allowed for the mRNA to survive in the cytosol and in the environment for longer. These two advances, basically mRNA being stable and tolerable enough for vaccines, right, that it didn't cause immediate immune reaction that then caused, kill the animal or the person. Those two things were very, very important for what happened later on, right? Now, that's not enough. We still have to deliver this item to the target cell. So another group had to develop what they call the lipid nanoparticles that protected the mRNA until it got to its target, right? Just to go across the cell membrane and get into the cell, it had to be protected. And that was developed between 2010 and 2014, right? So now you see, this thing started all the way here, 61, 90, 2005, 11, and then the first drug was developed in 2018, right? So all of that time, this work was in what's called discovery and preclinical research. It was in this step. And I'm just going to skip this, but what you know is all of these steps allowed us then to develop the COVID-19 vaccine. Because what did we solve? The stability, the immune reaction, the lipid particles that then that protected it and allowed it to be delivered, right? All of those allowed for us then to use it as a, to basically develop it fast when COVID-19 hit. So in your environment, what can you do, right? There are, of course, real world evidence and big data. There's, as medical students, it really always starts with questions, right? Ask the question and then look for the frameworks that work where, how do we test this? And develop your own ideas of how to solve the problems you're seeing around you in your environment. Hopefully we can train local researchers, and definitely before we are able to train local researchers, we got to have ethics boards and ways to approve studies before they're conducted. In my research environment, we can't do a simple survey of patients unless we have an approval, right? And then designing, appropriate, studies that are sensitive and culture responsive to your own environment is going to be a useful thing. So, conclusion, evidence-based medicine elevates care and public health. Ethics frameworks protect participants and build trust. Learning from failures. So all of these ethical failures that we saw have to then be learned from, and we have to improve our ethics guidelines. And innovation always demands both caution and empowerment, meaning, you guys need to feel like you can ask your own questions.
عدنان
Yeah.
سمعت بعد حدة مياه عدك
No, do you hear me? Hello? 1, 2, 3. 1, 2, 3. You can't hear me?
Yes, we can hear you from this side. I don't know about that side, their side.
Dr. Ibrahim can hear me, but you guys can't hear me? Hello? 1, 2, 3.
Yes, I can hear you, Doctor.
Yeah? How about the people in the hall? Well, yeah, قاعدة فردية ما مقليان.
والله ما ملينا
I can...
يا ما هو شغينا
يوسف مقليان يوسف عنده. Yeah.
قاس سمحوها طلب علي قاس
It's time for me, right?
دكتور عدنان سيدنا مخلص عنك.
أنا يوسف يعمل مقليها.
I think computer went to lunch early.
Well, I was going to show them some of my
I would love to see it.
some of my research. Huh? Yeah. Hello? You guys hear me? We can hear each other, but I don't know if you guys can hear me. ما يمقلش عن ذلك يوسف.
أنا أخو بغلط زوري. سمعنا. سيدا كلاوة نقول نقل أنا حاجة سمع عدوية بين غيرنا. 1 minute and سكوت أنا في السكر.
Okay, take your time. No problem.
حتى دكتور عدنان له هذا.
1, 2, 3. 1, 2, 3. كولا وصدح كولا وصدح. Dr. Ibrahim, you want
عادي أنا ولا سنة عادي سكورر.
يا مولانا الحمد لله.
Good to see you, ما شاء الله.
Good to see you. Good to see you.
How's the northeast?
The northeast والله وحوي aad bay u kulay sanadka. Yeah. We hear you. I hear you. aad bay u kulay. Dhowr week bay waxaan ku yiri.
لكن I thought you are too cold and then too hot.
ما taqaanaa because waxa weeyaan leekan agtayada ma aragtay ayaa humidity aan caadi ahayn ayuu sameeyay moogta
I said,
Yeah, you know, wherever I know a dry heat. That's a very different type of heat, you know?
I said we are a little bit better than you guys are.
Yeah.
We don't get too much cold, but heat is not as bad either. I said, what?
How is the humidity over there?
hadda waan idin maqli karnaa.
Waana maqlaysaa soo maa? Okay, good. Imise daqiiqaan haystaa? Haddaad iska...
Go ahead.
Yeah?
waqtigii waynu dhaafnayba laakiin waxaan ku siin doonaa 10 daqiiqo insha Allah waad ku soo conclude garaysid haddii abeed.
Okay. Okay, intii u dambeysay waan dhammaynayaa, and just to say, evidence-based medicine really makes, elevates care and public health, right? So it's important. Ethics frameworks protect the participants, the people who are, the volunteers, the research volunteers, and it builds trust. And, when there are mistakes, we should learn from those mistakes and be also honest and upfront about admitting that we made a mistake. And of course, innovation, you can innovate, but also it demands some level of caution. And ultimately, people at the local level have to be empowered to kind of address some of these problems. Now, quickly, I want to talk to you about my research. This is, what I study is concussions, gagapka. All of my research is in the discovery and clinical sort of stage. And we are looking into translation, meaning going from that level to hopefully basically trying to use what we're developing for patients. Now, what we talked about so far is medicine, that, a drug or a pill or something like that that you can give to a patient. But even diagnostic tests, right? So when you look at an MRI scan and you see a lesion, how do we know? So even that process of evidence creation that I was talking to you about applies to diagnostic tests, right? So in my case, I'm trying to develop an objective diagnostic test for concussions. So quickly, concussions are clinically defined, right? Transient confusion, someone marku gagabo, can be disoriented, impaired consciousness, usually loss of consciousness that lasts less than 30 minutes. Now, you do not need to have loss of consciousness to be concussed, right? But everything I'm telling you is not an objective test. This is just basically a clinical set of things, right? So a patient walks in, they tell you what happened, and they tell you their symptoms, and then you say you have a concussion. In that exchange, nothing objective was done. You didn't give them, there was no blood test. You didn't actually do probably an MRI scan, and I'll talk about that quick because nothing will be seen if it's just a concussion, you won't see anything. And so the goal is to figure out a way to test people, to come up with an objective test, right? The risk factors here, we're going to go fast. 8 children, less than 5 especially, are very sensitive to this. And a big group of the people with concussion, I didn't add that slide, about 30% of the people with concussion, they actually have continued symptoms, right? So many of them recover within 14 days, 2 weeks, but about 30%, called the miserable minority, continue to have symptoms as they, and some can have symptoms for the rest of their lives. Migraines, and such things, right? Now, the disease is considered to be a mechanical disease, meaning something happening, forces in your brain stretch the cells and the brain parts and causes the disease. I'm not going to explain all of this because it's going to take us long, and I'm going to quick. But basically, this is playing Australian rugby. These guys are hitting themselves in the head, and these usually they are very highly exposed to concussions. And then American football. These guys wear those big helmets and the shoulder pads and such in America, they also get a lot of concussions because they're hitting each other in the head a lot. This is just showing you a rotation of the head and how that is causing. Now, the question is, where is the lesion? You know, when you look inside the brain, what is most susceptible to injury, right? And so from animal studies and human post-mortem studies, we have found that a lot of the white matter, this is the gray matter of the brain, and the white matter is here, is the weakest link and is exposed to high shear strains, meaning they stretch a lot, and that stretching causes very subtle damage, very subtle damage. So if you looked at in the brain of these people, when, you know, someone with a concussion, not moderate TBI, right? Mild TBI is, concussion is mild TBI. If you looked at people with mild TBI and you looked inside their brain using regular MRI, you won't find any difference between them and those with concussion, you know, and normal people of their age. There's not going to be much of a difference. So the question really is, where should we be looking, and can we develop a diagnostic marker? Now, there's an advanced MRI technique I use called diffusion MRI. It's sensitive, but it's not sensitive to the whole brain. So if you just looked at the whole brain and looked for injury, you won't find it using diffusion MRI. But if you pinpointed a very specific part of the brain, you could potentially find the injury, right? And so we developed basically we said we're going to find tracks that are sensitive to concussive injury, and those will serve as a marker for injury, right? And the criteria I developed was these tracks need to be associated with clinically relevant dysfunction in concussion patients. They need to be in a region that is you know, something called biomechanically susceptible, meaning there's something that makes them inherently susceptible. And these brain regions have to be affected in neurodegeneration later on, because a lot of people with concussion or TBI develop neurodegeneration. So these regions have to show up in that as well, right? So that's the criteria I developed. And I said one region that qualifies is what's called the midbrain, right? It's the middle of the brain. It controls a lot of, you know, a lot of our functions, eye movements and such. And so I said the region we're going to look at is in the midbrain. And using this advanced MRI, I'm going to look the white matter in that one little region. So a small, basically, region, right? And, you know, lo and behold, what we did was we took two groups first. We took a bunch of football players, American football players, and we measured all the hits they take to the head, right? So this is showing you, you know, all the hits, you know, they hit each other. So one will get hit from here, one here. And so you have hundreds of hits to the head. And we showed that that region shows you the amount of hits they took to the head, the damage in that region that we looked at, this region here, right? Combining this and this shows you is correlated with the amount of damage, amount of hits they took to the head. Now, interestingly enough, except for two people, none of these people actually had a concussion. So these people had damage to the head, although they didn't get, you know, a clinical concussion, what's called a clinical concussion. We replicated this in a group of people with concussion, controls compared to MTBI. And we showed also that MTBI in that region, they had basically lowered integrity of their white matter in the midbrain, right? I didn't like, you know, this was great. You know, we published this work, but I just didn't like how I selected the region. And so we did more studies. Are someone talking? Anyway, Abdul Qadir, so next I developed basically an MRI technique to look for, you know, this susceptibility. This was based on a hypothesis. We said this region is susceptible. I didn't test its susceptibility when it comes to its biomechanics. I developed another tool where now we can look at the vulnerability of the whole brain, right? And what this color shows you is when you hit a person in the head, the regions that light up, these regions that are light up, are the regions that end up having. I'm hearing a lot of feedback.
qofka ay cabdiqadar ugu qoran tahay please telefoonka iska xid kamarada iska xid qofka cabdiqadar ugu qoran tahay.
Okay, so now we directly measured where the forces, when you hit a person in the head or someone gets hit in the head, where the forces will be the most. And what this shows you, the different colors, are different levels of forces. So all the forces are concentrated, as you can see, in a lot of the gray matter, what's called the gray matter, right? Now, this is what people used to say, the place that's the weakest link is in the white matter. But when we measure the forces, we're seeing a lot of the forces are concentrated in the gray matter, right? So now there's a problem, right? The evidence before us was saying, look at the white matter. The evidence we're showing when we do direct tests is showing us to look in the gray matter. And I said, why are we not seeing a lot of, why weren't we seeing differences in the gray matter before? So I'll show you a negative test. When you look at the gray matter using the old method that people used to look at the brain, so this is a group of people with concussion, MTBI, and their controls, and you compared them across their gray matter. This is basically gray matter points, right? They were on top of each other. There was no difference between gray matter and white matter. This is a group of people who were scanned. They had the MRI scan 7 days. Within 2 days after they had the concussion, this group got scanned between 2 weeks and 90 days, and this group got scanned between 90 days and greater than 90 days, right? And so when you compare, each one has two groups, right? A control group and an MTBI, and you can't see a difference between the two. This is the old way of testing things, right? In the gray matter. So I had a hunch that the method we were using to test the gray matter was wrong. It was not sensitive to give us a gray matter, to tell us anything about the gray matter. And we developed a new marker called AFD. So this one's called FA, fractional anisotropy. We developed a new method. Now, the same group of people, right? You couldn't see the difference between MTBI and control in any of the three cohorts. When you use this new method, you end up seeing really huge differences, right? So before, a lot of people said there was no problem with gray matter in concussion. It's a purely white matter disease. And here we show for the first time that this is not the case, and it's because they were using the wrong method. And this is just to show you that all of the work we're doing is in this stage of, I will go back because we are still in discovery and preclinical phase of studies. And okay, thank you so much for your attention. And sorry, I went over a little bit. Hello?
Yeah, excellent. Thanks for sharing that. That's cutting edge.
Oh, thanks.
MashaAllah, MashaAllah.
Hopefully waa la yara fahmay waxaan ka hadlayo.
Yeah.
aad baa umahadsan tahay Dr. Adnan. Dr. Adnan was researcher in the neuroscience and surgery jaamacad la yidhaahdo Rochester oo ku taala New York. wax su'aalo miyay jiraan kolay salaadiina waa ina haysaa waa inaynu rawaxi doonaa. Any question? runtii researchka aad iyo aad buu muhiim u yahay, dhammaanteenna waa laynaga rabaa runtii wax yar yar baynu ku bilaabi karnaa oo daynugu hareeraysan oo maaragtay aynu haddii ay beed maayo hadhowtana aynu magaranaysa hore u socon karno marka iminka isku dayaha yaryar aynu samaynay iminka haddaynu eegno iminka kuwaas oo kale waa ilaa 8 9 ray weeyaan beber oo internationally la daabacay runtii oo aynu inagu maaragtay marka yacni haddii aynu bilowno runtii steps yaryar hore aynu u soconaynaa waxaynu samayn karnaa insha allahu tacaala hadhowto inaynu aynu maaragtay dee hore ugu sii socono oo aynu maaragtay researchka hore ugu maaragtay inagoo hadhowto aan dee laynooma baahnaba iminka inaynu cilmi cusub runtii keenno laakiin waxyaalaha yaryar aynugu hareeraysan aad arkaysaan ayaynu maaragtay ku bilaabi karnaa oo dee dunidu iminka appreciate garayn kartaa waxyaalaha yaryar aad arkaysaan aynu ka samaynay iskuullada burco cusbitaalka burco iyo waxa ku hareeraysan runtii dunida oo dhan ayaa nalagala soo xidhiidhaa oo maaragtay la yidhaha noo kaalay oo na tus oo noo sharax bal waxaanaad qabateen waxaanaad samayseen ilaa iyo emailkaagu buuxsamo oo 24 saaca lagu soo diro casuumaad noo kaalay noo sharax waan aragnay researchkaagii marka dhammaanteen insha allahu tacaala waa inaynu 1 2 3 steps aynu gelino researchka innaguna iminka xaggaas runtii waynu fahanay muhiimadda uu leeyahay waanaynu u soo jeesanay waanaynu samaynaynaa waxaa laga yaabaa ayaamaha soo socda insha allah inaynu cilmi baadhsiyo fara badan aynu soo bandhigno jazaakum allah khayr aad iyo aad baa u mahadsantihiin doctor ibrahim iyo doctor cadnaan jazaakum allah khayr salaadii duhur baa annaga nahaysa iminka waanu tegaynaa aad iyo aad baa u mahadsantihiin berritana waa soo xidhan doonaa insha allahu tacaala xilli hore aynu nimaadno buuqa ha la yareeyo dad badan baa jiro aan isregister garayn inay inamada u tagaan oo isregister gareeyaan dhammaantiin aad iyo aad baa u mahadsantihiin allah idin barakeeyo السلام عليكم ورحمة الله وبركاته
السلام عليكم أنا فجر كيف أنا هي ما شاء الله السلام عليكم
السلام
No. Listen, you what? No. Hello? Zero. Zero. Brother, you wouldn't. هضمك مقلي هضمك مقلي اي ورق والله كنا انا اي وي والله والله الحراره كون تعال غير ما نقطع حاجه واروى الكاميرات انا ما والله قص قناه والله قص قناه اروى الكاميرات دو كاميرات عسيرو يا صوت والله والله كم خطوات يا صوت خلدي يا صوت خلدي يا صوت ميرو خلدي waxa way dhide عرب 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 يا عرب والله ما شاء الله ونروح حسابتك بردانه يا اه ده وانا تيم كي waxa ku dhahdaa warangal fiican ka qaada sawirka caadi ka qaada aad waxaas leedahay malaha waa profesorada caadiga ah anaa bas garan waaye aniga laftigeyga is garan waaye si waxan ma adiga ma والله بي ما شاء الله وين كافد ذا سما كافد هذه هذا صوت لي ورد انت في صوت قطع انتم يعني عارف كده waxa la oranay odayga بي ولي صوت طبعا انا كان waxaan kuu soo dirayaa kii shirka oo dhammaystiran oo kuu soo forward gareyn ay brother
Mm.